Services and Elderly Affairs. We have several Senate bills to be heard today, but before we get to those, I'd like you to please join me in the Pledge of Allegiance. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. The first bill to be heard today is Senate Bill 130 FN, which the prime sponsor of is Senator Rochford. Senator Rochford, I'm assuming, cannot be with us this morning, so ably standing in for him is Grant Bossy from the Senate staff. Deputy Chief of Staff, is that the proper title?
That is correct.
Okay. Thank you.
Thank you, Chairman McDonald and members of the committee. My name is Grant Bossy, here to introduce Senate Bill 130 on behalf of Senator Rochford, the bill's prime sponsor. This bill began life as a prohibition on balance billing for ambulance services, but at the initial public hearing, Senator Rochford brought in a replace all amendment to create a commission to study delivery models for emergency medical services. The delivery of emergency medical services is an acute and complex issue, especially in his district. They are being delivered in a number of ways, but some services are being lost in the North Country. The commission would study various delivery models, some of which may be more appropriate for different parts of the state. Would also examine the state's role in addressing this problem and any legislation that could be brought forward. The commission is balanced to bring forward all the key stakeholders, including fire and ambulance, hospitals, towns and counties, and insurance providers. While we are asking committees to think twice before creating new studies due to the lack of office space this summer, Senator Rochford believes emergency medical service delivery merits the time and attention we'll need to craft legislation for next year. One oversight, we typically attach such study commissions administratively to state agencies. We'd suggest an amendment administratively attaching this commission to DHHS should the committee agree to its creation. If you have any questions, I'll make sure Senator Rochford gets you an answer. Senator Rochford thanks you for your consideration and support for Senate Bill 130. Thank you.
Thank you. Are you taking any questions yourself, or?
I will take them. I will likely not answer them, but I'll make sure you get an answer.
Okay, yes, Representative Palmer.
So I had two questions. I mean, obviously, we see that there's a huge problem in rural areas with getting patients transported. And I certainly have had the experience of having a very sick patient not be able to go anywhere and making me very nervous. So I think this is a great idea. The two questions I have, one is, I know that our ER staff is working in a, our ER staff, is that better? Huh, how about that? That was 1 inch difference, okay. That our ER director is working with a group in New Hampshire and Vermont on this, and I don't know if that there was any testimony or any knowledge of that, of what's already going on. And then the second thing is, in the list of people who are listed to be on the commission, there's no like emergency room medical director, anything like that, and that might be a worthy addition, just because, as I said, a bunch of them are trying to work on this.
So to I think, address both your questions, yes, this commission would, I think, take in work that's already being done and invite those people in. Commissions are very open-ended. They can invite anybody in they'd want. But if you think somebody should actually sit on the commission and give a seat, I don't think Senator Rochford would be opposed to that if you think an additional person should be given a seat at the table instead of in the audience.
I mean, given that now requires, I mean, if that's going to be then part of the quorum, that might not be such a good idea, but I would want to make sure that group gets invited.
Yeah, that's a policy decision. Obviously, the thing with study commissions is they are not closed off just to the voting members. They can invite anybody they want to come participate. Their public meetings are open to the public, so even if they don't want to hear from somebody, they're welcome to sit in the audience and be part of the proceedings. But whether you actually add a seat on the commission, that's a policy decision up to this committee.
Anyone else? I do have something, if you could share it with Senator Rochford. And I think you touched on it briefly a moment ago or during your testimony, but as we know, there are hundreds of commissions and study committees, and in many cases, even the speaker, and he's got a lot more to draw from than the Senate president, obviously, even he is struggling to fill these seats. And even when he fills them, oftentimes people don't show up. So the efficacy of any proposed new commission is of great concern because we want it to work. We want it to fulfill its mission. So obviously we're just hearing this bill and we're going to give it due consideration. But it is a concern we have with all commissions and study committees. And if you could share that with them, that'd be great.
Well, especially next year where this building will not be available. And so meeting space for study committees and study commissions will be at a premium. We think the threshold for creating these commissions should be a little higher this session than it has been in the past. But Senator Rochford thinks this clears that threshold. And it's up to you to decide whether you agree.
Okay, great. Thank you very much.
Thank you.
Anyone else?
Okay.
Representative McKay. Thank you.
Thank you, Mr. Chairman. There already exists a study committee. It's called the Oversight Committee on Health and Human Services. But I don't know why this just wasn't referred to them.
Senator Rochford thought that there were some technical issues. For instance, we've got Representative Hunt's bill on ground ambulance services is being heard in Senate HHS in about 10 minutes. But he thought that there were some very specific issues for next year that this commission would be appropriate to solve.
Follow up.
Follow up.
I don't think that's an answer, but I know that you're not the sponsor of the bill. The existing study committee is well equipped to deal with all of those questions.
And I think that's a policy question you need to address. Senator Rochford thinks one way, you think another. That's fine.
Thank you.
Anyone else? Seeing no one. Thank you.
Thank you.
No one else is signed up to testify on SB 130FN. Do either of the gentlemen in the audience wish to? I take it no, so I'm going to close the public hearing on SB 130FN. Next hearing is at 10 a.m. on SB 133FN, so we will be in recess until then.
I don't know why. I keep bringing up that committee. It's as if it doesn't exist.
Okay. We are, while we wait to have the hearing on SB 133 FN at 10 a.m., we are going to proceed into executive session and discuss Senate Bill 18, and I'd like to recognize Representative Weber.
Thank you, Mr. Chairman. I am passing out an amendment. You will recall that Senate Bill 18 has to do with a pediatric intermediate care facility, of which there is only one in the state, and it is Cedar Crest, that's located in Keene, New Hampshire, in my county. And what this does is it authorizes additional beds there as needed. Some of you may remember that last term we passed a temporary authorization for 2 additional beds at the facility, but that will expire, I think, at the end of this fiscal year. And so this language in the bill we have in front of us allows for the creation of additional beds. It doesn't have an actual bed limit, but in order to add a bed, it has to be first recommended by the Commissioner of Health and Human Services, and then it has to be approved by the Fiscal Committee of the General Court. So there are careful controls on the amount of expansion. And the reason for the need is that Cedar Crest serves children that are both developmentally delayed and very medically fragile. And this is a population that it's very difficult to find appropriate and safe caregiving for. So they not only house children, they also provide respite care for children who are living with their families, so their families can take a break from what is a very intensive caregiving process. And this would allow the number of beds to expand and contract without having to come back to the legislature each time it's needed. I think it was a very carefully worked solution, and my hope is that it will meet with your approval. The amendment that I passed out simply in response to Representative Lucas's eagle eye takes the word immediate and changes it into intermediate, because in one place it said immediate rather than intermediate. So with that, I would offer Amendment 2025-1605H.
So you're moving on to pass, Representative?
Yes.
Is there a second? Representative Palmer seconds. Is there any other discussion on this amendment? Seeing none. When the clerk is ready, I'll ask him to call the roll.
Rep. Mazer?
Yes.
Rep. McLean? Not here. Rep. DeLamus?
Yes.
Rep. Kofalt?
Yes.
Rep. Polizov?
Yes.
Clerk votes yes. Rep. Markell?
He's not here.
Not here. Rep. McGrath?
Yes.
Rep. Kesselring?
He stepped out, I guess.
Oops.
He was here. All right. Rep. Weber?
Yes.
Rep. McKay?
Yes.
Rep. Woods?
Yeah.
Rep. Palmer?
Yes.
Rep. Tejas?
Yes.
Rep. Lamontagne?
Yes.
Rep. Hartnett?
Yes.
Rep. Lucas?
Yes.
And Rep. McDonald.
Yes.
Vote is 15-0. Passes.
Okay, 15-0, the motion to brought to pass on Amendment 1605H passes. Representative Weber, do you have another motion?
Yes, I would move on to pass as amended. Sorry, I move on to pass as amended by Amendment 2025-1605H on House Senate Bill 18.
Is there a second?
Second.
Representative Lucas seconds. Any discussion? Representative Weber, do you want to speak to your motion further, or?
I think I have spoken enough. There are no changes to what I would say.
Okay. Any other discussion? Okay, seeing none. When the clerk is ready, I'll ask him to call the roll.
Rep. Mazer?
Yes.
Rep. McLean? Rep. Delamus?
Yes.
Rep. Kofalt?
Yes.
Rep. Polizov?
Yes.
Clerk votes yes. Rep. Markel? It's not here. McGrath? Rep. McGrath? Did Steve come back? No. Okay. Rep. Weber?
Yes.
Rep. McKay?
Yes.
Rep. Woods?
Yes.
Rep. Palmer?
Yes.
Rep. Tejas?
Yes.
Rep. Lamontagne?
Yes.
Rep. Hartnett?
Yes.
Rep. Lucas?
Yes.
Rep. McDonald?
Yes.
Vote is 15-0. Motion passes.
Is there any objection to consent?
I will write you.
Okay, thank you very much. All right, excellent. Day is off to a very good start.
We just go home now.
Well, it's not off to that good a start, but it's off to a good one. Okay, we still have about 7 minutes before our next hearing, so we'll be in recess.
Thank you, Mr. Chairman, members of the committee.
Okay, yeah,
Sorry.
I'll reconvene and open the public hearing on SB 133 FN and welcome Senator McGue. Welcome.
Thank you, Mr. Chairman. Nice to see you, members of the committee. Sorry to be exactly on time. If you've looked
that's
out the
fine.
window, you may have seen a line of ambulances. Rest assured, there is no emergency, except that
Is that simply in support of this bill? Or-
except that for some reason in New Hampshire, we don't have first responders and ambulance service providers included in our definition of essential services. And that's what Senate Bill 133 aims to fix. I know it seems a bit silly. So I'll keep it pretty simple. It is, I hate to say housekeeping because sometimes that's the kiss of death in these bills. At least it is in my two committees across the way. But it's a little bit of housekeeping because the current statute language is a little bit too ambiguous. It merely states first responders. And in a lot of systems, a first responder is not the ambulance service. It could very well be a police officer, just a host of other things. So it opens the door for a lot of different problems, from billing to liability, all sorts of different things. So other states have already fixed this problem. Arizona, Montana, Indiana, our neighboring states, Massachusetts, Vermont, Maine, Connecticut, they've all streamlined these protocols by fixing this definition. So that's what this aims to do. I mean, you could imagine, God forbid we had have a problem like East Palestine, Ohio. Well, for any of you that happened to take a trip south or be coming north just yesterday, we didn't have anything nearly like that, but we did have a tanker truck. I happened to get caught in it for 3 hours. Flip over the guardrail yesterday, if anybody saw that. But imagine if it were much worse and we had a major problem like that. And just picture your local firefighters delaying their advance because there was some kind of procedural problem or, in the face of red tape. And then now imagine that the ambulance teams are encumbered, are encumbered by this similar red tape because the first responder has to be somebody else other than an ambulance provider. So we need to grant them the essential status and streamline their operations and make sure they can just take action decisively without any fear of administrative repercussions. That's all this bill does. I'll give the clerk some written testimony and ask you to look favorably on this bill like the Senate did. Appreciate your support on it. I'm
Any
happy to
questions?
take any questions on how this bill works.
Representative Palazov.
Thank you, Mr. Chair, and thank you for taking my question. Do you have any details on what are those billing problems and liability problems? Can you give some examples?
That's a great question. Some of the industry folks who would love to answer that question have packed the halls downstairs on the first floor. The ambulance bill rate bill is being heard as we speak. So they are not present behind me right at this moment. But I can tell you from 30 some years as a licensed provider, it's those types of issues that we ran into during the pandemic and when we started to define exactly what an essential service was or wasn't, when government started drawing lines and classifying different occupations, we just chose to designate first responders as a catch-all. And while that definition exists in statute, so does ambulance providers. So I probably can't point to a specific billing or program issue, but I can tell you for third-party payment, it's emergency provider or emergency service provider, one of those two. And that definition is a catch-all that includes ambulance providers. So that's why we have to include that. So in our statute now, emergency services provider actually includes things even like a hospital, like a non-moving entity, or an urgent care clinic. It's a very broad definition. So this helps include specifically an ambulance provider in that for any purpose. I hope that makes sense.
Any other questions? Representative Weber?
Would it be fair to say that what this language does is just clear up confusion about what I would have assumed was already included under the statute, but which is not explicit? And this makes it clearer that it does indeed cover these services as well as all the other ones that we think of as first providers.
Thank you, Representative Weber, for your question. Nice to see you again twice in one morning. And yes, that is exactly correct. When this bill was brought to my attention by a member of our technical college paramedic program, who actually, by the way, they expressed their apologies. They'd all be here today. It's their airway exam today, and they all came and testified on the other side, but they have their airway exam, otherwise that whole group would be here. They brought it to my attention, and I said, well, certainly we are considered essential services now. And they pointed out, in fact, as you've duly noted, this clears it up that, in fact, the ambulance providers were left out in that. So that's what this does.
Representative Kesselring?
Thank you, Mr. Chair, and thank you for taking my question. So reading through this, I had a curiosity. Is there any other training that would be necessary based on the RSA to add them to this?
Other training?
Yeah, so because you had mentioned, the tanker that flipped over and things, because based on this provision, it almost looks like there was some extra training that these classifications of people have to go through specifically.
No, I don't believe there would be any additional training requirement. No.
Okay.
No.
Anyone else? Representative Woods, did you have your hand up?
No.
Oh, okay, I'm sorry. Okay. Anyone else? I'm seeing no one else. Okay, thank you, Senator.
Thank
Could
you,
we
Mr.
get a
Chairman.
pink card from you, by the way?
Yes, certainly.
Thank you.
I'll fill out 2 of them, one for the next one too.
Okay, yeah, that's coming up. Okay, and I'm assuming neither of the gentlemen in the audience wishes to testify on this either, so. Okay, no one else has signed up to testify, and so we're going to close the public hearing on SB 133 FN, and the next hearing is scheduled for 10:30 on SB 138, which was also recognized, at which time Senator McGee will be back as the prime
Tell him.
sponsor.
Suggest it.
Mr. Chair?
Good. Yes.
Just a suggestion. This seems to be fairly straightforward. Would it be advantageous to everybody just to go ahead and exec this?
That was what I was thinking myself. Is there any objection? I'm sorry?
It's a great minds think alike.
No
Yes, there we go.
objection here. I might as well.
Anyone
go
in the
ahead.
room have any objection, or does either party feel a caucus is needed before we consider this an executive session?
Okay, hold on. Let me get my acting.
Okay, seeing no objection, we'll proceed.
Gary.
Again, we've closed the public hearing on SB 133 FN, and I want to open an executive session to consider SB 133 FN by the committee. With that, does anybody have a motion? Representative Woods moves out to pass on SB 133 FN. Is there a second? Representative DeLamas seconds. Representative Woods, would you like to speak to your motion?
I think this is actually redundant. It does clarify, but the previous phrase says emergency medical services. Certainly an ambulance qualifies in that regard, but as the senator pointed out, this just is further clarifications for the reasons that he outlined. It was more for the administration side rather than for the application side in the field. 'Cause clearly an ambulance is an emergency medical service by definition. So it's, in a sense, it's a redundant, and I see no reason that that it shouldn't be included if it's enhances the ability for administrative purposes. It will have no function as when a 911 call is made. There'll be no difference.
Okay, thank you. Anyone else? Any other discussion? Seeing none, I'll ask the clerk to call the roll. Again, the motion is ought to pass on Senate Bill 133 FN. Mr. Clerk, when you're ready.
Rep Mazer,
Yes.
Rep McLean is still not here. Rep Delamus,
Yes.
Rep Kofalt,
Yes.
Rep Polzov,
Yes.
clerk votes yes. Rep Markel is still not here. Rep McGrath,
Yes.
Rep Kesselring,
Yes.
Rep Weber,
Yes.
Rep McKay,
Yes.
Rep Woods,
Yes.
Rep Palmer,
Yes.
Rep Tejas,
Yes.
Rep LaMontagne,
Yes.
Rep Hartnett,
Yes.
Rep Lucas,
Yes.
Rep McDonald.
Yes.
Vote is 16-0, motion passes.
Okay. Okay. Representative Weber moves consent. Is there any objection? Okay, we'll put that on consent.
Report.
Representative Woods, are you writing the, what, before? Okay, thank you.
You started it.
Okay, very good. Representative Delema seconded. So again, thank you, everyone, and we have still about 18 minutes to go, so we'll be in recess until 10:30. Okay, I'd like to reconvene and open the public hearing for SB 138, and once again recognize Senator Tim McHugh.
Thank you, Mr. Chairman. Good morning once again, members of the committee. Nice to see you. Thank you so much for your action on Senate Bill 133. It's greatly appreciated. This one, I hope, is just as easy. It is.
By the way, Senator, did you give us the pink card yet?
I did, yes. I'm Senator Tim McHugh. I represent.
Oh, I'm sorry. Okay, thank you.
I represent Senate District 11, Merrimack, Amherst, Milford, and Wilton. And I'm here to introduce Senate Bill 138, which is relative to record requests by healthcare providers. And I did send in some, or pass in one copy of written testimony also. So hopefully this is a little bit of common sense legislation. We've all spent a lot of time watching the news, talking about efficiency in government and efficiency in healthcare. And I'm sure everyone here has one time or another requested some medical records or had to bring a CD or DVD with them to get a copy of their imaging, just to be sure that when you went to the next appointment, you had them with you. Well, sometimes, as you've probably all experienced this too, that you've experienced a delay in care, going to an appointment that you're waiting for only to find out that the specialist hasn't seen your chart yet or hasn't seen your loved one's images yet. So the idea behind this bill is to streamline that process. Right now, New Hampshire law gives medical record holders up to 30 days to release records, even when another healthcare provider requests them. Dr. Woods probably has experienced the same thing in his lengthy career. So if you're a physician trying to adjust medications for a heart patient, this can possibly lead to a delay in hospitalization. I know that it did for my father. If you're, especially when they were trying to titrate his blood pressure medications. If you're a paramedic trying to stabilize a critical patient, you might be missing some critical records in the big set of records that you're sent that are sent along with you during a critical care transport. So missing records can mean guessing instead of knowing. So we are hoping that we can find a way to do better. Other states already have. Texas requires healthcare providers to furnish records within 15 days. Arizona, 14 days. Montana, even in their vast rural areas, have figured out a way to streamline this electronically. So in my opinion, New Hampshire shouldn't be lagging behind. You might ask, would this somehow create a burden or a financial cost to medical offices? And the answer is emphatically no. The reality is that most records today are digital. So if a system can generate a patient's bill within seconds for revenue cycle management, this whole industry is based on that, I believe that a chart can be sent just as fast. Indiana recognized exactly that and set a 10-day deadline for electronic record transfers. And so this bill really isn't asking for the impossible, it's just aligning our laws with modern capabilities. And the idea is simply to improve patient outcomes. So almost every bit of legislation that I'll get strongly behind, like this one, has something to do with making somebody healthier, faster, getting them back to their families, getting them back to be a productive member of society. And this bill indirectly does just that. Helps improve patient outcomes. So I ask you to look favorably on it, just as the other body did, and support it, hopefully, just as fast as you did Senate Bill 133. So thank you again for that. There are some folks behind me that can talk to some of the technicalities and how it affects their institutions very directly. The Senate did amend it to add a study committee at the request of one particular party. I don't have a strong feeling either way on the study committee. It wasn't part of the bill as introduced. So what you choose to do with that part of the bill, I'm a little bit indifferent on. Happy to take questions. And if you have really technical ones in terms of how charts or records or those things migrate through a facility, I know that there are a couple of experts behind me that can speak to the machinations of hospital administration and billing.
Any questions for Senator McHugh? Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. So in general, this bill is trying to change chapter on medical records and medical records. So as you said, one reason to release this private information is to help with the next doctor as next healthcare provider, but also sometimes state has interest in doing some research. So what do you think about medical records of people who are already deceased? Would you be open to an amendment for easier access to medical records if person is already dead?
I think that'd be better approached in separate legislation. I think this bill, if you think about the Health Information Privacy and Portability Act, affectionately known as HIPAA, I think this helps us provide your information, right? It's your information, where you want it and when you want it to get there. So I think information on deceased individuals is used for a lot of different things, insurance claims, estate management. So I think maybe that's better addressed in separate legislation. I think we could go down a road or kind of get in the weeds, so to speak, if we tried to address that in this piece. I'd be happy to look at that. We have a number of bits of legislation dealing with birth and death records. I've had in my committees on the other side of the law. I'd be happy to work with you and look at that, but maybe in a separate piece I think would be better.
Thank you.
You have a follow-up?
Different question, if I may.
Okay, go ahead.
Thank you for entertaining my other question. So, what you are trying to do with this bill? What's the underlying problem here? Is it electronic medical record problem, the way it's structured, or is it competition problem that doctors don't want to release their data to other doctors? What's the underlying problem?
So simply put, it takes too long to get your medical records to another provider and delays care. Simple. One doctor refers to another, and the other doctor that gets the referral can't look at your data fast enough to take care of you and provide care.
Other questions? Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. Turns out this problem's been studied a fair amount. It was part of a committee maybe 20 years ago, maybe, at the AMA. And we had to shut it down because of the difficulty of the problem centered around the platforms of each of the electronic providers couldn't speak to one another. So my question then is, have you looked at the 14 days? I haven't recently, in terms of getting the electronic form, because it says transferred, because most electronic medical records can't be directly transferred. In other words, if my office uses one platform for a medical record, it can't understand the platform from somebody else's office. Therefore, the transfer must be rather lengthy, I would think, in the sense of transferring it to paper and then snail mail or whatever in some other form, and that's a lot of work, and that's difficulty in the platform. Very similar to the same way that X-rays had different photographic platforms, and now there's a common photographic platform such that I can put my X-rays from my office on a CD, and it's a common platform. Again, I've been out of this for a little bit with the AMAs for about 15 years. So has that 14 days has a strong foundation?
It sure does. Representative Woods, Dr. Woods, thank you so much for bringing that question up. Nothing I like more than getting in the weeds on the technical part. So I'll try to keep it brief because I could talk a while on this one. It's something I know a little bit about. Suffice to say, a lot has changed in the last 15, 20 years, even in the last couple of years or last 5 years. So here's the brief state of affairs. There are a number of very common connectors, HL7 connectors that are universally recognized as standards in the healthcare industry, HIPAA compliant, AWS hosted. AWS is probably the most commonly adopted. AWS is Amazon Web Services. They're the largest provider for HIPAA compliant HL7 connectors that are built into things like Meditech, T-Systems, Cerner, Allscripts. Those are some of the biggest providers of healthcare information systems that handle PHI, protected health information. I personally built out a large remote patient monitoring system to handle PHI during COVID and clinically distanced vital sign monitoring, highly sensitive information. And those types of universal standards are used for this, and the transfers occur in a HIPAA compliant environment handling reams of PHI data in 15 seconds or less. It is sometimes one of the integration challenges when a hospital migrates from one system to another or when institutions merge. But transferring records, the standards have long been adopted for transferring records electronically. So that's the good news. And a lot of people figured out that there was a need and figured out that this was a great entrepreneurial opportunity, which is why those standards exist.
I'm glad to see things have changed.
Yep.
Any other, Representative Palmer?
So, thank you, Mr. Chair. Thank you for taking my question, Senator. This is a little bit related to Dr. Wood's question. I practice the hospital's actually in Vermont, and we have a record called Cerner, which is now just a few months away from disappearing. And right now, we can't transfer records electronically. So when somebody requests them, we print them out and fax them. That's going to go away. I don't know if other platforms in New Hampshire have that problem, and I wouldn't argue with the date requirement. I just say that, we might need to. There might be other practices that have an electronic medical record, but they can't send them electronically to somebody else. And maybe some just little exception needs to be made for that. But maybe other people know if that's, I know it's going away for us because we're moving to Epic, but I don't know if that's a problem for anybody else. And obviously if they can print them out and fax them in, hopefully in less than 24 hours, because last weekend I was still waiting for records on a patient, but that's where I was going with that.
Thank you for your comment. I'm not sure, was there a question?
Well, the question was, could we have an exception so that if they could not send them electronically, even if they have an EMR, would they be allowed to, at least in the interim, send paper records?
Thank you for the question, Representative Palmer. And I feel your pain making the migration from Cerner Allscripts to Epic, as expensive as it will be for your institution. I think 30 days is more than enough to figure it out and email a file in a HIPAA compliant fashion. That's my personal opinion. And I think that delaying a patient's care any longer than that for receipt of records, I think is not acceptable.
Well, no, and I think 14 days is plenty. I just didn't want to have somebody get penalized for sending paper instead of electronic.
Well, I'll leave that decision to the committee. My preference would be to facilitate electronic transfer as fast as possible to facilitate a better outcome and speedier care for the patient. Yeah.
Representative Palazzo.
To clarify on previous question, what kind of penalties we are talking about if somebody won't be compliant with this recommendation? Are there some penalties, or is it just best practice?
That's an excellent question. I don't think we have a penalty attached to this. And I don't think that's it. I don't believe we have a penalty attached unless there's one in the overriding chapter, and I have a feeling one of the folks behind me can probably answer that.
Anyone else? Seeing no one else, thank you.
Thank you, Mr. Chairman. Thank you.
Yes, Representative Lamus, you have a question? Don't.
Thank you, Mr. Chairman. On line 23, or actually 24, all records being provided pursuant to
Just give me
request.
1 second. Let me bring the bill back
I'm
out of
sorry.
the folder here. Hang on.
I'm sorry
Just backing up
to
here. Hang on. Line what? I'm sorry.
interrupt your packing.
Line what?
23 and 24.
Page-
Actually, that on page 1.
Page 1, line 23 and 24?
Yeah, records being provided pursuant to request by a requester shall be provided to the requester within 30 days. Shouldn't that be removed if we're moving to 14?
No, I think 30 days is the intent of the bill. Thank you for your question, though.
Oh,
Sure, Representative Weber.
thank you.
So isn't the point of the inserted language at the top of page 2, which is the new language, to make it clear that just the medical records going to another provider are under the 14-day provision, and stuff going to everybody else is far less exigent, so it could go under the 30-day provision?
Representative Weber, thank you so much for clarifying. It's provider to provider
Yeah.
within 2 weeks. Yeah. Which is often the time it takes to get the appointment scheduled anyways. Yeah. Thank you so much.
Anyone else? Okay, thank you, Senator. Also signed up to speak is Malcolm Perry from Berry Medical Center.
I concur with all the comments.
Will you turn your mic on? Thank you.
Thank you, Mr. Chairman. I concur with all the comments that Senator McHugh has made this morning, and I testify in support of this bill. My name's Malcolm Perry. I'm the Chief Executive Officer for Dairy Medical Center. We have around 80 providers serving 7 communities in New Hampshire and over 100,000 patients. I've been in healthcare my entire career, 38 years, and I can tell you this is an issue that has bothered me for quite some time. I'm going to speak to you today a little bit about what patients do experience. There was a medical office, a primary care office that closed over in Somersworth last month. They gave their patients 30 days notice. Then they shut their doors, and these patients, these 7,000 patients, had to pay $50 to $60 to $70 to get a copy of their record from a third-party vendor so that they could transfer care to another primary care office. That's just wrong. When a patient is requesting or a provider is requesting medical information to provide continuity of care and access to care, it should be done in a timely manner, and it should not be at the cost of the patient. I find it very interesting. My wife and I took a little vacation a year ago. We had to go to the vet and get a copy of the Milo's vaccination history in order to board the dog. I was provided that free of charge, but I can't get records without paying $50. It's just wrong. So that's just a personal example, and it happens all the time. Hospitals have outsourced this activity to third-party vendors. They have no problem transferring medical records from a primary care office to this. Frankly, they're on the same platform anyway. But if you have to go to see a specialist that that particular hospital does not employ, very often they're charging the patient to transfer medical records to a specialist to provide care. And I think this bill speaks to that. The differentiation as to who the requester is was not in the current statute, and we're seeking to clarify that a provider request for medical records should stand outside of other requests, and it should be done in a timely manner, and it should not be at any cost to the patient. Thank you.
Thank you, Representative Weber.
So that's very interesting. and concerning report from you, because I'm recalling that we had a bill on this section last term that was about the acquisition of records for the purposes of a lawsuit. And at that point, my recollection was that we were told very firmly that if the patient themselves requested the records, which it says quite clearly in existing statute on line on the first paragraph, those records are the property of the patient, and certainly we were told, I think, that patients were given copies of their records without charge. So if that's not clear, would you have any objection to revising the statute, the provision here, in a way that makes it clear that whether it's the patient requesting the records directly for themselves or the provider who is going to take a referral on the patient, that there shouldn't be any charge for the patient either?
There shouldn't be. Every health institution and practice has a release of what they call a release of information form that they need to get the patient's authorization to release their record. I think there's been some misinterpretation of what that request is. If the patient is putting where they want their record to go to another provider, then they're getting charged. I don't know if they're just requesting records and getting charged, but in all, practicality, it's the same thing. You're trying to get your records to another provider to provide continuity of care, and I think that's how some I won't disparage anyone, but I think that's how people are getting around charging patients, because they think it's being transferred. They're asking for a transfer of their record to another provider and not for the patient themselves.
So as a follow-up, if we put in language that perhaps on the top of page 2, if I can't draft this quickly enough in my head, but if it said something like, when the requester of medical records is the patient themselves for their own personal use, or the person's health care provider, which is the language that's in here, would that be troubling to you, or would that put a monkey wrench in the works in any way?
It wouldn't be troubling at all. It wouldn't be troubling at all. I think that the language in the existing statute was a little bit confusing as to who could be charged and who couldn't. And it all gets back to who the requester is.
Right.
So, a further clarification of patient and healthcare provider within 14 days at no cost would certainly be appropriate and take care of this.
Thank you.
You're welcome.
Anyone else? Representative McGrath.
I was under the impression that your insurance company covers some transfer charges for records.
Not to my knowledge. No.
Other questions? Representative Palazzo.
Thank you, Mr. Chair. Thank you for taking my question. So reading the bill and also reading the underlying chapter, I see no penalties for breaking this law. So do you feel like there need to be some explicit penalty listed in this chapter?
Well, I wouldn't oppose it, but I'd like to think that healthcare organizations would follow the law and not violate it. I think imposing penalties is really not. I sort of akin it to when people have no-show appointments and you try to charge them for a no-show. You're just chasing money. You're not really going to get that. What you really want to try to do is get patients to respect the provider's times and call when they have to cancel. It's a little bit like that to me, that you can impose a penalty, but I don't think that's the major point here. It's not to penalize people. It's really about this whole bill, to me anyway, is patient access and patient continuity of care. I have primary care doctors that see. We register 12,000 new patients every year. And a lot of times my docs go into an exam room. The patient's been scheduled for, 4 weeks and they still don't have records. And if you've been to a primary care doctor for 30 years and you have some chronic conditions, a lot of patients are not good historians of their medical history. And you're asking a doctor to take a look at you and you've got high blood pressure and you've got, other conditions. They have no med history. They have no history of your, they have no medical history. They're guessing and it's a little dangerous. It's a number of times doctors have told me that they actually don't want to see a patient until they get their record. But again, patients change providers for a lot of different reasons. They move, their provider retires, an office closes. The patient shouldn't be put in the middle of this. They just shouldn't. It's dangerous.
Thank you.
Anyone else? Seeing no one else, thank you.
Thank you very much.
Also signed up to speak is Ben Bradley from the New Hampshire Hospital Association.
Thank you, Mr. Chairman. For the record, my name is Ben Bradley, and I represent the New Hampshire Hospital Association and its 26 acute care hospital members, as well as all specialty hospitals. I just want to be clear, we very much support timely access to medical records and ensuring there is not a delay in care. I'm here to share some information that was not provided to the Senate committee in testimony. And just ask for your consideration. It's our position that the Board of Medicine rules MED 501.02 under their standards of conduct for licensed providers already outlines the expectation for the transfer of medical records from one provider to another. And that's the enforcement mechanism, Representative Polazov, if I may, is that it is part of your standard of conduct as a provider to be transferring these records in a timely way. Specifically, the rule states, quote, "The responsible party shall promptly honor all requests made by a patient or an authorized agent of a patient for complete copies of the patient's medical record in accordance with the following standards." Among those standards includes number 4, which reads, "Upon receipt of a written release, the requested transfer of medical records shall, A, not be delayed, including for non-payment of services or non-payment of copying costs and of costs for transmitting of medical records." So transmitting those medical records shall not be delayed on the basis of whether it has been paid for or there's a cost affiliated or not. And B, be accomplished in any case within 30 days from receipt of the signed release, unless the nature of the medical treatment requires an immediate response from the licensee. These are rules that were established by the New Hampshire Board of Medicine, not by the legislature. We believe the regulations for transfer of medical records belong with the Board of Medicine, and this issue does not call for legislative intervention. If the proponents of this bill feel providers are not compliant with the board's rules or feel there needs to be a change in practice, the board already has the authority to act or make necessary and appropriate changes to their rules. We are not aware of any complaints filed to the board for noncompliance with the existing rules. This committee should consider whether the existing avenues for noncompliance have been explored before legislating a change. Finally, this bill was amended by the Senate to add a new legislative committee to study access to medical records, an issue that came up last year, had been contemplated, and this body passed into law, the governor signed into law. Again, we're not aware of any noncompliance with existing statutes, and therefore do not believe this issue rises to the level of needing a separate legislative study committee. For these reasons, we can't support SB 138 and request the committee ITL. Thank you. I'm happy to take questions.
Thank you. Representative Lucas.
Thank you, Mr. Chair, and thanks for taking my question.
Thank you, Representative.
You cited a code of conduct pertaining to physicians and transfer of record providers. Is there anything similar that holds hospitals to that same standard?
It's the provider that is transferring the medical record, so it would be the expectation of the provider that may work in a hospital to ensure those records are transferred.
Follow-up?
Follow-up?
So, services that are rendered in an emergency setting, x-rays, lab, would fall under the auspices of the ER director?
Yep. And hospitals, if there's a request of the hospital to be transferring a medical record, those are governed by HIPAA and New Hampshire statute already. The Board of Medicine regulates the provider's behavior, and hospitals, I just want to make clear, when a patient requests medical records for themselves, I'm not aware of any hospital that charges for their medical record.
Thank you.
Representative Palazoff and then Representative Weber.
Thank you, Mr. Chair, and thank you for taking my question. Do you know if any hospital provide patients with a paperwork saying that if they experience some issues, they can file a complaint with New Hampshire Board of Medicine?
If we provide that to them, I'm not sure. I would have to look into that.
Thank you.
Representative Weber.
Thank you, and I'm glad as a follow-up to all the discussions last term that you have stated that hospitals don't charge patients individually to provide them with their records. But my concern is that having heard from the earlier testifier that at least a closing medical practice, patients had to pay for their own records. Do you have any objection? I understand that you object to the whole thing, but do you have concerns about my inserting the language that makes it much clearer or makes it explicit that no patient is going to be charged by anybody for acquiring the records that already belong to them? That's question number one.
I was listening to you over there and contemplating the question when you first asked. And a couple of things I would say. One is I'll get back to you on whether that would be an issue. I don't believe it would be. When the patient makes a request for their own medical record, they own the medical record as New Hampshire law outlines and you stated. Massachusetts says that a patient has a right to one free copy of their medical record. That's something that I just looked up and found, but happy to work with you on language, Representative Weber, if that's of interest to you, respectively outside of this legislation.
Follow-up?
And the follow-up, I would say, is that no, I'll just save that for an executive session.
Okay. Representative Kesselring.
Thank you, Mr. Chair. Thank you for taking my question.
Sure.
So I heard what you said about that the legislature shouldn't have the place unless the medical board does. But as far as the 14 days go specifically, do you think that falls outside of what is a possibility, let's say, for all of this to happen?
I think that should be contemplated by the Board of Medicine. I don't have an answer for you whether that's an appropriate timeline at this time.
Anyone else? Seeing no one else, thank you.
Thank you, Mr. Chair.
Also signed up to speak is Holly, I believe it's Holly Haynes from NHHA. Is it Haynes or, okay.
And thank you, committee, for allowing me to speak today. My name is Holly Haynes. I'm an attorney at Abramson, Brown & Dugan in Manchester, New Hampshire. And I'm here on behalf of the New Hampshire Association for Justice, which is a statewide group of trial attorneys who work to ensure patients have access to the justice system. In my practice, I represent patients who have been harmed by medical care, and we routinely have to request medical records. Last session, this committee knows from last session, and from the prior testimony, getting access to medical records has been a problem for years. It's been attempted to be addressed at the federal level through regulations, but it takes years and years for those regulations to get enacted and to get implemented. This legislature and this committee specifically took a good first step last year, a good common sense first step in ensuring that patients get prompt access to their medical records and their requesters get access and for a reasonable price. This bill is a common sense extension of that, and I'm here in favor of this bill. Before I get to, I wanted to address some of the ongoing problems that have happened since the statute was changed last year, and also address the things that have happened beneficially since the statute was changed. But first, I'd just like to address a couple of comments from Mr. Bradley for the Hospital Association that I think may be somewhat inaccurate. First and foremost, Mr. Bradley stated that hospitals don't charge patients for medical records. The reason that may or may not be the case, but the reason the hospitals don't charge directly is because they're contracting with third-party data vendors who are the ones who are charging patients directly. These third-party data vendors are the biggest problem in this, and they're frankly the reason we need a study committee in New Hampshire to address this issue and to get all of the stakeholders at the table, doctors, medical providers, medical practices, hospitals, lawyers, and patients. What happens is these hospitals contract with these third-party data vendors who are mining patient information and generating these records. The hospitals don't pay these third-party providers. The data vendors are profiting from this because they're passing the charges on to the patients, they're passing the charges on to providers, other treating providers, they're passing the charges on to anyone else who requests the records. That's the only reason that hospitals are not charging, because they're the ones that are using these third-party vendors. I can tell you, since the statute was changed last year, our clients and our practice has changed substantially. Every smaller medical practice in the state, every solo provider, smaller hospitals, smaller groups are providing records in record time, under 30 days, usually within 14 days, and within the statutory cap of $50 or less, and sometimes free. Dartmouth never charges patients for medical records or imaging. They're the one hospital in the state that does not. One other inaccuracy, that providers at hospitals are the ones providing medical records and not the hospital. That's just wrong. And I believe Malcolm Perry would be happy to speak to this as well. Hospitals have dedicated medical records departments. They have dedicated medical imaging departments. When a request for information goes in for a patient's record, it goes to the medical records department. It doesn't go to the hospital. One of the ongoing problems that we've had with this, and it's specifically the third-party data vendors, they are charging the $50 fee, but they are essentially holding records hostage for patients, requiring them to agree to all sorts of additional fees like data archive fees, online access fees, retrieval fees, and certification fees that they're tacking onto the $50. I actually have our response to this has been we send back a check for $50 with the request and don't respond further. We got an email Tuesday, April 15th, 2025 at 8:40 a.m. from DataBant, which is one of the third-party providers, in response to our $50 check that says, "Thank you for your response. Upon review, I will confirm that the fee for medical record requests is $50. Additionally, there is an excess fee of $13, which includes a certification fee of $11 and an electronic archive fee of $2. These charges still apply because your patient has opted to access their records via a patient portal. The charge is valid, and the records are not available to the patient until they pay the extra $13. That should not be the case. And I have the email from DataBant. That's this week. That's the most recent example that we have in our office. So these third-party vendors are not complying with the statute. That's the biggest problem. Medical providers in New Hampshire are complying with the statute. Dairy Medical Center is complying with the statute. Individual providers are complying with the statute. Doctors are. But this is a problem, and I think we really need a study committee to address this. Going back to a few questions that were raised by Representative Woods and others about the 14-day requirement and the reasonableness. In the 21st Century Cures Act was passed in 2016. In 2021, the federal government, Department of Health and Human Services, Office of Civil Rights changed the mandated time for disclosure of medical records or release of medical records to 15 days from 30 days. The federal standard under HIPAA was always 30 days. That's what's written into the Board of Medicine regulation. That was changed to 15 days. Unfortunately, they keep delaying, as happens with federal regulations, the implementation deadline for it, and they don't have penalties, specific penalties that are imposed, and they've been trying to come up with penalties for when providers don't comply. So in response to if the 2 weeks or 14 days is reasonable, the federal government has already said 15 days is reasonable, so I think 14 shouldn't be a problem, especially with electronic records. The other issue with the Cures Act under federal law is the interoperability of these platforms between providers, because it is a problem. It used to be that Catholic Medical Center, the emergency room, used a different provider than their floor did. So if a patient went into the emergency room and was admitted to the floor, the doctor on the floor had no access to their emergency record the same day, which makes no sense. These platforms are supposed to be operable. Under the Cures Act, they should all be interoperable. And under the Cures Act, these records are supposed to be available promptly, freely, within 15 days, and in an interoperable data format that is easily accessible and transferable amongst providers and patients through any portal or other way. And the recommended way is by PDF if there's not interoperability between the platform. It should be able to be saved to a PDF and provided that way. I'm happy to take any questions that you may have, but I think that these ongoing problems, as you've heard from Senator McHugh, from Dr. Perry, and from others, and some of the inaccuracies we've heard from the Hospital Association show there's still problems with this system, and there shouldn't be. Patients should be able to access their information. Their doctors should be able to access their information. Their lawyers should be able to access their information when it's needed. It's needed for many things. It's not just lawsuits. They need it for insurance coverage claims. They need it for disability applications. They need it for transferring medical care. There are many, many reasons why patients need access to their information. They should be able to get it quickly and freely. And I'm happy to take any questions you may have.
Okay. Thank you. Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. So two-part question. First part, do you agree that all these problems would go away if you and your client would just file a complaint with New Hampshire Board of Medicine? And second part, so hospitals are somewhat controlled by New Hampshire Board of Medicine, but does the board control those third-party data vendors or medical record departments?
So thank you for your question, Representative Peloso. And I'm sorry if I mispronounced your name. The Board of Medicine does not control third-party data vendors. They are not subject to the regulation of the Board of Medicine. Hospitals and hospital medical record departments are not subject to the Board of Medicine regulations. They're subject to the New Hampshire Hospital Association. The Board of Medicine governs medicine. It governs physicians and licensing of physicians and the provision of medical care by physicians. If our patients ever filed a complaint with the Board of Medicine about it, I can tell you just based on past experience when they filed complaints about anything, it would not be addressed in a timely manner, and it would take far more than the 30 days that they already have under the statute to get anything done. It would take at least 6 months to a year, maybe more. And I know that there are study committees going on now about the Board of Medicine, and the federal state medical boards have been looking into this as well.
Representative Weber.
Thank you for taking my question, and going back to the testimony last year and the testimony we've heard here today, would you have an objection if I put in a specific amendment in the language that's being added to the statute to make it clearer that when the information is provided directly to the patient, that they should not have to pay for it to anybody?
I would be completely in favor of that.
Okay, thank you.
And Representative Weber, if I may, I would submit that an amendment to make 14 days applicable to all medical records requests would even be reasonable. And if we could go further and make them free for anyone.
Well, I know, but I may not be willing to go that far.
I understand. Thank you, Representative.
Representative Kesselring.
Thank you, Mr. Chair. Thank you for taking my question. So I got stuck in my head now what you said about the other companies that are charging. Is there a reason they're doing that? Is because they just don't feel like that there's any need to do it to follow the law, let's say, or, based on what you said?
Interestingly, we've actually, in what generated this email, we've had back and forths with Datavant, which is the largest third-party vendor. They own Ciox and ShareCare, who most of the New Hampshire hospitals contract with. This request, that email I read to you, was for a request for records from Portsmouth Hospital specifically. But they also govern Concord Hospital, Elliott Hospital, Catholic Medical Center, all of the major hospitals other than Dartmouth. They say that they're complying with the statute because their invoiced charge only charges $50 for the medical record. It's just they're adding these fees that are not authorized. And in fact, the statute specifically says that additional fees, it should include all applicable fees, the $50 cap. And we routinely go back to Datavant's counsel, to the people sending the invoices, and we send them a copy of the statute with that highlighted, that this includes all applicable fees, $50, here's our check for $50. And this is just the most recent response. So I'm not sure why they are still charging them. And I do understand Kyle Probst, who is counsel for Datavant, he is aware of this issue. He testified to the legislature last year in opposition to the changes, but he knows that they have not been complying, and he tells us that they're looking into it. I'm not optimistic, but there is a dialogue going on, and maybe they need to be included in the discussion of any study committee because they aren't complying.
A follow-up.
So I just want to clarify. So Representative Weber had mentioned to add that in there. So there's no kind of reason for them to even follow it at this point if they're not following, or if they're charging now. So would that change anything if that provision was added, do you think, on their end?
I don't know. It would be interesting to see if a patient requests what they get for an invoice or if they receive an invoice. I don't know the answer to that. We would have to see how it happens in practice. I think that's what we're learning now with these additional fees. They're creating additional fees because they have to make a profit. They're a for-profit entity. So they're seeing what additional fees they can charge.
Representative Weber?
So if I'm recalling correctly, isn't it true that when we had this discussion last term, the hospitals contract with these third parties because, particularly with respect to litigation, the medical records have to be reviewed because this is going to attorneys and outside the hospital care sphere, and they need to find out if there's anything that needs to be redacted. They need to find out if there's anything in the records that perhaps was misfiled or miscategorized and put in somebody else's file, so that they're not releasing anything that it's impermissible for them to release. And what we were told, and correct me if I'm wrong, was that the third-party vendors are the people who review the records prior to release to make sure that everything is dealt with according to Hoyle, so that the hospitals don't have to do that. But So am I correct in remembering that that's what we were told, and could that be a reasonable basis for why it may be reasonable to take longer in some circumstances, but not in the circumstance where the requestor is the person whose records they are, or the new healthcare provider who needs their records as soon as possible in order to provide appropriate care?
Thank you, Representative Weber, and I hope that I understood completely. Your recollection of the testimony, I believe, is accurate. That was the testimony from Datavant's counsel, Kyle Probst. And I believe our response to that was that they do have to go through steps to produce records. That's why there should be a charge of some sort, and I think that's what arose to the $50 cap on electronic fees, because there needs to be an administrative charge. In reality, they aren't doing that. They're looking at an authorization and making sure that it complies with HIPAA, and they're downloading the records. We receive records from other patients' records and charts all the time, and the requests that we receive. So they aren't taking the time to do that. They aren't actually doing it. They are downloading, and it may be misfiling issues. It may be that no one's looking at it, but that's happening with us. I'm sure it happens at times with doctors' offices. If they request their patient's chart, they're probably occasionally getting pages from another patient's chart. It happens. They aren't spending time doing that, though. At least in our experience, we just get a pile of records that may or may not be all of our clients. And another issue that has come up in litigation, at least, if we move forward into a suit, part of litigation or a lawsuit is what's called automatic disclosure. So if we bring a medical malpractice claim against a hospital or a medical provider, their counsel has to provide us with a complete copy of the medical records in their automatic disclosure. We previously requested a complete copy of the medical records and received it from the third-party vendor. The counsel for the hospital is not getting it from the third-party vendor. They're getting it from their client directly. We're routinely getting thousands of extra pages from their counsel in the automatic disclosures that our client never got in our initial request for records. So that's one other issue that does come up. And the issue with these third-party data vendors, and I understand Mr. Radley, I suspect, has talked with some of the hospitals in his group. We've taken to calling counsel for the hospitals directly, counsel for Concord Hospital, counsel for the Elliott Hospital. They aren't aware that these third-party data vendors are doing this. When we tell them the difficulty that our clients are having accessing their medical records and the charges that they're getting, they're shocked, and usually that counsel will go to the medical records department and get us a copy of the records at no charge. So they don't know that this is going on, the hospitals themselves, because the medical records departments are separate. The counsel and the administration may or may not be aware that it's going on unless someone brings it to their attention, which is why I do think they need to be a part of any committee that is there. I think it would be very helpful to have counsel or someone from administration at a few hospitals there.
Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. Couple of things. Are you providing any kind of summary for the committee? Some of the aspects, especially the third-party data vendors, is of some interest, especially if it's paralleled with the PBMs in the pharmacy arena. This would be very interesting. Are you providing any summary?
I haven't, but I'm happy to do so after the hearing if you'd like.
If you could, that would be wonderful. One of my concerns is the complete medical record. We were talking earlier about the platforms, and there's a separate platform for my x-rays. X-rays are part, MRIs are part, CT scans are part, echoes are part, but those are in a very different format.
Yep.
Now, is it expected for the same price, meaning zero, to have those transmitted and available to the patient in a format that's readable? Because if I in my office, I'm retired, but if I'm still practicing, if I get an x-ray file from another provider, that's part of the medical record, I can put it in my computer because I have on my computer the special program that will interpret that. But your computer does not. So getting the information is buried in there, the requirement that it be in a readable format for the patient.
Thank you for your question, Representative Woods. And it's been my experience that every request we make to imaging departments for CT scans, X-rays, MRIs, any sort echoes, usually come with a viewer. They come with the viewer platform on the CD.
Okay.
Usually the imaging is downloaded to a CD by the radiology department, and
Right.
It gives you a viewer application that most computers can open. I think some Macs may have problems with it,
Yeah,
but most computers can open them. And there is usually a separate charge by imaging departments. It is a separate request. We make one request to the imaging department, one request to the medical records department, and there is a separate charge for that. Usually it's a $10 charge for the CD.
One last follow-up.
Sure, follow up.
Does this bill adequately cover that difference between the studies that are being done versus just the printed vocal record, shall we say? Is that adequately covered?
I don't know that it is even covered at all in this bill, Representative, but I can tell you, we have never had a problem with the radiology because it's never a third-party vendor that's dealing with it. It's always the hospital's radiology department that's putting it on a disc. They charge you for the disc and they provide it. It's never been a problem. And most, I think, physician offices, usually imaging is done at a hospital anyhow, or they're referred to a hospital or an outpatient center, so they're going to be able to provide the disc with the viewer.
Thank you.
Anyone else? Okay, seeing no one else, thank you.
Thank you, Chairman.
No one else has signed up to speak on SB 138. Does anyone else wish to? Seeing no one, I'm going to close the public hearing on SB 138. Our next hearing is scheduled for 1 p.m. on SB 134 FN. We will be in recess until then. Good afternoon, everyone, and welcome back to the House Committee on Health, Human Services, and Elderly Affairs. The next bill to be heard today is Senate Bill 134 FN, and to introduce it, I'll recognize Senator Howard Pearl.
Well, good afternoon, and I think this is my first time in front of House HHS, but it's good to be back over on the House side.
Welcome back.
Spent a few years here on E&A. For the record, my name is Senator Howard Pearl from District 17, and I reside in the town of Loudoun. I am here today to introduce Senate Bill 134. Excuse me. We are a state that prides itself on work to support our families, independence, and self-sufficiency. Work requirements will help low-income families by offering them a way out of poverty. Medicaid and other welfare programs should be a bridge for non-aged, non-disabled adults, not a destination. Today, we have work requirements built into our food stamp and temporary aid for needy families programs. This should be no different because the policy is the same. Work helps, work helps families reach independence and is a core value in promoting health and wellness. Additionally, the Heritage Foundation has provided research of the hidden costs of staying on the Medicaid program, and that could be up to $323,000 in foregone lifetime wages for men and up to $212,000 in lost lifetime wages for women. Thus, encouraging low-income individuals to work more could significantly improve living standards. This taken together and along with other work requirements that currently exist in social programs improves health and welfare of individuals. I want to be clear. This bill and the waiver that will proceed applies to those that are capable of working, and exemptions will be built into the waiver, like we have had in the past, that take into account any of the reasonable exemptions that should apply, such as where a single mom is caring for an infant child. I think this should be good policy for our state, and I would encourage you to send a positive recommendation to the full floor of ought to pass. Thank you.
Thank you, Representative Weber.
Thank you very much for taking my question and welcome back. I'm wondering why the specifics of those exemptions haven't been placed into the statute and instead just left to an amorphous waiver when we, the legislature, are the people who ought to be determining what those are.
Well, I think the important thing is that the waiver will work through, and if I remember, John, it goes to the council, correct? The executive council for approval. I thought, okay, I think fiscal committee. I'm sorry, that's right. It's fiscal committee. We did send it through the fiscal committee to overlook the waiver and make sure that the requirements that we were putting in there were what represented the legislature. So they will have some input on what these waivers exemptions would look like. Follow up.
But there will be no review whatsoever by any policy committee of the legislature, is that correct?
Correct, because of the timing that occurs. So it was the best we could do was put it through the fiscal committee.
Representative Woods.
Thank you, Mr. Chair, and thank you, Senator, for taking my question. I need some refreshing. I was here for the last round of the work requirement, and we discussed it. It wended its way through the courts up to the U.S. Supreme Court, and it was basically shelved. Can you bring me up to date with the previous waiver, having taken that track and had that come down with that verdict? Can you help us understand how this would be different, and what is the impact of that decision on this waiver application?
Sure. No, that is a great question and a fair one. I would prefer to let Councilor Stephen answer that. He's going to testify, and he had experience with that waiver process in the past. So I think he'll give you a better and more cognitive answer than I can. But thank you for the question.
Representative Lamontagne.
Thank you, Mr. Chair, and thank you for taking my question. What percentage of people on Medicaid are already working?
I don't have the exact statistics. I know that there have been studies done in the past. I just think it's a good policy for our state to we are a working state and we're a family state. And I think it's just a great policy for us to have that. And I don't know the exact percentage. I know it's fairly high, but I think this would impact the state on, especially on a budget year like this. We're looking to make some savings, and my understanding is the fiscal impact would be quite beneficial to us as we move forward. It would take a little time to get there. I respect that. There'll be a little bit of an initial outlay, but I think in the long term, it's a good policy and a good fiscal policy for us.
Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question.
Sure.
So we had, at least on paper, work requirements in the past, and I'm assuming that waivers were a part of that. Is it the intention then of the fiscal committee, do you have any commitments from them, that they would be building these waivers on our historical, waivers for being able to work? And do you have any kind of feel or what they look like?
Sure, that's a great question. I mean, we're going to rely heavily on HHS to guide us forward on what's going to be acceptable to the current administration in DC. They know the qualifications that they have to work within, and the fiscal committee will have the ability to just look that over and make sure that that we're really, sufficing the intent of the legislators if it passes, assuming. You're welcome. I've got time for one or two more, and I apologize. I have another bill I have to introduce. They've got me scheduled really tight today.
I understand. Representative Markell and then Representative Lucas.
Thank you, Mr. Chairman, and thank you for taking my question.
Sure.
Sir, can you tell me how many other states have enacted legislation similar to this and what the results have been?
I know of one for sure that we're just starting back into it. Again, the administration change in DC is going to make this more of an appetite to have these go through. The work requirement hasn't been successful in the past, but I feel we have a better chance now of getting that waiver passed.
Quick follow-up. Thank you, sir. Can you tell me what kind of impact this might have on federal aid to our state regarding Medicaid?
I can't. I don't know the answer to that one, but I believe Councilor Stevens would probably give you a better insight on that as he's worked with it in the past.
Okay, thank you.
Representative Lucas.
Thank you, Mr. Chair, and
thank
you for taking my question, Senator. Sort of the obverse of the question about how many people on Medicaid work, what's the percentage who will qualify for the waivers?
Again, and thank you for the question. That's a little difficult to answer because it would depend on what the actual stipulations and the exemptions in the waiver would be. So that would be a hard one for me to answer. But I'm told that it would have a positive financial impact on our state. So that's the best I can give you right now because I don't have the detail on what the waiver would look like exactly.
Are you done?
Maybe one more quick one.
Okay. Any more questions? I think we're done.
All right.
Okay, thank you. Just as a reminder to those of you who haven't been in front of our committee before, we usually do give extra time to testimony by the prime sponsor so that they can explain the background and the genesis of the bill. Moving forward, we do ask you to keep your testimony to 3 minutes, and then that allows for questions from the committee, as well as the opportunity for others to speak and to testify. And with that, we've heard a lot about him already, so I'll recognize Executive Counselor John Stephen.
Thank you. Thank you, Mr. Chairman. Mr. Chairman, honorable members of the committee, my name is John Stephen for the record, and it was 2007 when I was last before this committee. So it's a great thing to come back, and it's a great bill to come back on. And I have two main reasons. I'm speaking really on behalf of myself, my experience being a prior commissioner. I can answer as many questions I hope I can answer for you, but the department really are the subject matter experts here as well. So they tried this in 17 and I know it was stopped by the former administration. It never did get to the Supreme Court. And one of the reasons is there's questions on is this an objective of the Medicaid program? And that gets down into a lot of legal issues. However, there are states currently, Ohio, Louisiana, Iowa, Arkansas, Kentucky, a few others have already submitted waivers. There's nothing stopping the Department of Health and Human Services today from sending a waiver to Washington. There's nothing. This is important though. This bill is the policy. It would be a policy statement that we really value work. And as Chairman McDonald remembers, because he was one of my employees when I was a commissioner and did a great job for us, we in 2006 passed one of the most transformative TANF laws, temporary aid to needy families, which requires work in the entire United States. Our work engagement level when I took over as commissioner was somewhere in the 15-16% range. When we passed that law in 2006 and really focused on those TANF work engagement principles, we went to 40% work requirement in TANF, one of the top in the United States. I think New Hampshire was number one year, and then when I left, it was number 2. We really did a great job. Everyone got together. We helped those people in need, but we also tried to help people move to self-sufficiency and independence. That's always been my goal as commissioner, and also when I was working at the Department of Safety, working with victims and helping people to make sure that they can help their own families. And it's a 2-gen model that I care deeply about, 2-generation, helping mom and dad, you're helping the children as well. And so the issue then becomes, for me, we have a low unemployment rate in New Hampshire. We have a need for capacity. We have an able-bodied workforce that's on Medicaid expansion. This waiver has to require exemptions following the TANF law. Those exemptions are so that people that are disabled, rightly disabled and unable to work, aren't going to be forced to work. We're going to work with those that can work and are able. That's why they call it able-bodied. That's the Medicaid expansion law. And these individuals have the ability to work. Some are currently working, and they can get the benefit. This will enhance, in my opinion, even as executive counselor, this will have Department of Employment Security, the bureaus there, the districts, their providers, working closely with HHS, working closely with economic agencies in this state, looking at all the different programs they offer through the Workforce Investment Opportunity Act, which comes from the Department of Labor, the Social Service Block Grant, which goes to all your community action agencies, and your TANF dollars.
If you could start wrapping up.
So my wrap up is that I really feel this is a strong policy statement. The state already made this. There's other states moving in this direction. Congress is going to move in this direction. We need to take a lead in New Hampshire and say we prioritize work and self-sufficiency. And that's what this bill is about. Be happy to answer any questions.
Thank you. Representative Weber.
So am I correct in thinking, thank you very much for taking my question. My understanding is this applies only to the Granted Advantage program, not to the traditional Medicaid recipients.
That's my understanding. It would be on Medicaid expansion, but I haven't looked closely at that issue.
So am I to understand that these are the people who already have too much income to be included in traditional Medicaid, which says to me that many of them are already working. So do you have any statistics about what the percentage of the population is that is working, what the percentage of the population is that would qualify for an exemption, and presumably anybody who's disabled would be receiving traditional Medicaid, not the Granted Advantage program. So how that all works together.
I don't have those statistics, Representative, but the department should be able to tell you that. I mean, I don't have access to the current data of the program, but that's a simple survey that could be done.
Representative Kofal.
Thank you, Mr. Chairman, and thank you for taking my question. So you mentioned other states moving in this direction. Can you speak to what specifically other states are doing, and are there any states that you see could be an effective model for New Hampshire in terms of a waiver and sort of constructing the waiver?
Thank you, Representative, for that question. Yes, I finished working in 2024 for Governor Huckabee Sanders, and she was the first state to actually do the waiver in Arkansas. I'm very familiar with that waiver. I've written it from beginning to end. It's a great waiver. It's one the state of New Hampshire commissioner and her department should look at. I have a lot of faith that the department knows how to draft waivers in New Hampshire. They've done it in the past. They've got a lot of really innovative waivers. So I trust them. I don't, in the House or in the Senate, I heard their testimony that it may cost $1 million or so to write a waiver. Totally, I I absolutely dispute that. There is so many waivers out there that you can look at a template, you can get some people together, work with some policymakers, and you could come up with a waiver for the stakes. You already did it in 2017, and it shouldn't cost a lot. And they're competent, and I'm sure New Hampshire DHHS will be able to write and give to the fiscal committee a very valid, sound waiver for New Hampshire, especially with the leadership of Governor Ayotte.
Any, Representative Woods and then Representative Kesselring.
Thank you, Mr. Chair. This is a correction to what I said earlier, and the comment was absolutely correct. I said the Supreme Court, and I didn't pay close enough attention to my notes. So for the record, it was the Federal District Court and the Federal Circuit Court of Appeals that heard the waiver. So my apologies for speaking incorrectly.
Thank you. Representative Kesselring.
Thank you, Mr. Chair, and thank you for taking my question. So I'm looking through this fiscal note that was given to us, and there's a lot of details. It actually says that 20,000 people will lose their coverage according to this, but I'm seeing there's a ton of positions that will be needed, a bunch of spending that will be needed based on the fiscal note. I wonder if you could just, since you've got experience in this, could you walk me through, have you seen the fiscal note, first of all?
I haven't read it. I have not read it, Representative, but I heard it alluded to by the staff in the Senate hearing.
Okay, because with this, I guess the question would be, there's a ton of information in here that says that it's going to cost a lot of money and it's going to take a lot of resources.
So I'm going to give you my experience as commissioner of HHS. I would not have allowed my staff to come to this body and say that there was that much of a fiscal impact from what I heard in the Senate. Absolutely not. At the end of the day, there are close to 2,500 positions over there. And they have competent people that can write this waiver and do it on behalf of the citizens of the state. And I don't believe that you need to have a lot of technology costs, which I think they're alluding to, and other things to make sure you track and monitor when you already have a lot of current systems out there working with these individuals to find jobs and connect to the state. So I disagree with that high cost. Is there going to be some cost? Yes. Will it be outweighed substantially by the amount of people that are going to be working and not just save the taxpayer, but help their families? Yes. I hope that answers your question.
Representative McLean.
Yeah, and thank you, Mr. Chair. Thank you for my question. So, and I don't have that fiscal note in front of me, but is that 20,000 coming off because they're working and that moves them outside of the income requirement range? And also, just as a follow-up to that, because this was never fully enacted before because of the court issues that we discussed, but you did say back in the first decade where we did it, actually had the work requirements with TANF. So could you also speak to that, what we saw with the fall off rate from participation in TANF when the work requirements, was it a big hit, a little hit? So I'm just trying to get a feel for what drives the transition and how big it is.
And that's a great question. So we had our TANF rolls went down, I think, around 20% at the time. And I don't know if that was over a 2-year period. But the good news on that is, again, the state agencies started working harder together. There was a lot of collaboration, and there were families that were getting assistance in communities that they didn't even know existed. Community college grants, sponsorships, working with the WIOA programs under at the time, Department of Employment Security. It's been transferred now. They have these one-stop centers. So the jobs that people had, especially at TANF in our state, such a low, these are for people that are really not bringing in a lot of income for their families. And they need that help. That's why TANF is a T, temporary, for a reason. It's to help them move to that next level. I like the fact that 20,000, I like that. I want 20,000 to move to that next level in their lives. And again, the disabled individuals that need Medicaid are not going to be impacted here. There's also really important for the committee to know the TANF rules allow for community volunteerism. So that's up to 80 hours a month of volunteering in your community at a required volunteer activity that's currently in the law with Department of Employment Security and other departments under the WIOA is part of this.
Follow up.
So, and I'm not familiar with the original work waiver rules that were in place in 2017, but I'm hoping that they would dovetail a little bit into what would be in place here. Did those also include, that 80 hours for?
Yes.
So they did, okay.
I would ask the department that to make sure. What I did see though, I went back to the 2017, I wasn't here at the time watching it, but Commissioner Myers, Jeff Myers was the commissioner, and they had already worked with the Department of Employment Security. They had gone out to the community, they had done trainings, they had really worked with a lot of their workforce agencies. There was a lot of work done in this state. We were gonna be a model for the country, in my opinion. DHHS really stepped up, working with employment security to do a great job, which they will in this case, I'm sure, if they're required to.
Did I see a hand over here a moment ago? Okay. Representative Weber, sorry.
Thank you. Thank you for taking another question. So am I right in thinking that if we pass this as it's been presented to us, the legislature will have no further input at all as to what that waiver contains except those members who are on the fiscal committee? Is that correct?
That's correct, and it's not unusual. I mean, the community choice waiver for seniors, which is thousands of seniors in the community that get care that are nursing facility eligible. You can ask the department this, but that waiver was a great waiver. The substance abuse waiver that we got, the IMD waiver, I don't think any of those waivers went to the policy committees either. That's something the department does because you give the role and responsibility to the department. I think you're going one step further by doing the fiscal committee. You're making sure that they're looking at the waiver to make sure that there's nothing in there that they feel will impact the state. Because that waiver should have been, in my opinion, it should have been already written, but it hopefully will be written quickly, and then we're going to go through the court issue. There's no way you're not going to see the court issue anyways, but let that play out. But New Hampshire needs to be ready to go here, in my opinion.
Other questions? Seeing none. Thank you. Also signed up to speak are Henry Lippman and Karen Hebert from the Department of Health and Human Services. 6 minutes.
Pull the seat over. Mr. Chairman, I would hope that we could have 6 minutes combined because I have quite a bit of information.
Yeah,
I think that would be
we'll
good.
allow you 3 minutes each. Yeah.
Okay.
6 minutes combined.
Thank you. On the matter of policy, there is a current statute on the book. The way the department interprets this legislation is that we're to implement what's currently in effect in 126 AA:2, sections 3 through 10, which does represent all of the input that the legislature had when it was enacted. And so that's, I think, one point. I just want to make sure that's understood, that the way we're looking at it, the law is still on the books. And that is what we, as our understanding, we would need to submit a waiver on based on this legislation. So that's point one. And we'd be happy to, after the meeting here, share those relevant pages so the committee could look that over. I also just clean up that it wouldn't, if we were resubmitting the waiver, there'd be practically no cost that we would incur in submitting the waiver. In terms of tenure in the program, the average tenure in Medicaid, the Granted Advantage program, is under a year. The aspect of work, I'm not going to comment. I think that's a policy decision. I think there are good arguments as to why encouraging people to lift themselves up and get a better economic circumstance. There is also 3 bills in Congress currently that deal with a federal work requirement. There's also a possibility that a state plan amendment option for implementing the work requirement may be available. There's not certainty on that, but we've got an indication that that may be the case, which would be a less expensive way for the state to implement a program. Thirdly, or fourthly, actually, at this point, in terms of savings and costs, the part that we identified is the cost would be to pick up where we left off in terms of restarting that system and bringing it up to current connectivity with all the other changes that have been made in the system. If you read through what was required in the work requirement, and I have looked at Georgia and I've looked at Arkansas, which Councilor Stephen referenced. Georgia has a much different approach than what is contained in our law. They look at whether they're working upon eligibility and then on redetermination. Just to give you one example of what's in our law that has costs associated with it is that people have to submit information every single month. The requirement in our law is currently 100 hours. I think Councilor Stephen was correct that there are a lot of exemptions, but all those exemptions require manual intervention to review them. We also require a person to go to for some of the exemptions, to go to a physician or some other provider to get written documentation that they agree that they are deserving of the exemption. So handling all that stuff and many other instances of adjudicating the exemption requests, plus having to evaluate every single month whether they meet the requirement. And our law provides for what we call a cure period. A cure period gives a chance person to make up hours in a subsequent period. Again, tracking that, evaluating it all takes time and people to do so. We did actually get to implementing our work requirement. We submitted the waiver, it was approved, we started the implementation, we had initial reporting. So the numbers that are reflected in our fiscal note, which I think are greatly captured by LBA and the fiscal note that's attached to the bill currently, and I did see it is online, so if you don't have it.
We do have it.
Okay. We agree largely with those with small nuances with what they put together. It's very, I think, how the department sees having to stand this up. That being said, there are other options. As I mentioned, Georgia does it more simply. They have a lower hour requirement. I think they're at 80 hours. They only look at it twice, once on eligibility and then annually thereafter. Arkansas has an 80-hour requirement compared to 100 hours here. Their waiver request, rather than people losing coverage, people get, which their original waiver did, they have what they call a coaching component to it. In our number of 20,000 roughly that we assume potentially would lose coverage, our experience was that just before the court shut it down, there were over 16,000 individuals who had not been able to comply with the reporting requirements. Our population in Granite Advantage is a little larger today than it was back then. And so basically we applied the same percentage. And then with respect to
if you could start wrapping up.
So I guess the bottom line here is the department saying it can be done. We're recommending financially that if looking at from a pure finance standpoint, it will take a lot of money to stand it up and to administer it under what's in the statute. And we have experience because we built it and implemented it previously that like for example, system costs, we have $4.4 million that we've already spent in total funds. 75% of it was federal. We do have to bring the system forward because we have to allow people to report what they're doing. We have to ingest information from them, and we have to ingest it in an electronic way to make it feasible.
So would it be the personnel costs of tracking everything? Is that what you're talking about?
Yes, exactly. And then we also had call center capabilities, and I'll let Karen speak to that, to be able to answer questions and guide people and orient them to the program. So I'm not here to say do or don't do a work requirement. We do have one on the books. This one, I think, is one that I think deserves a second look based on what other states who have implemented are doing it and based on the cost. I'll close on the cost standpoint. Granted Advantage has today, under current law, has no general funds. So the savings from a cost standpoint, the way the non-federal share is funded, at 10% based on today's premiums would be equal to $4.3 million worth of savings directly. The other point that we want to share with you, and we have some handouts that I know we don't have time to show now, but we'll provide to you, is that there's a number of people that use Granted Advantage today are people who would otherwise potentially qualify for another eligibility level, typically disabilities. A person has a disability, they need health care, they'll take Granted Advantage while they work something out. If they don't have Granted Advantage as an option, they may end up on a regular Medicaid program where we pick up 50% of the cost under general funds. So we have an estimate of the number of people that you'll see that's contained in the fiscal note. If you're doing it for economic reasons, I just want to share there's not a savings to be had, particularly in this biennium. If you want to promote work, that's a different story, and not arguing against that.
All right, why don't we go to questions, and a lot of this will be brought out, I'm sure, in the answers you offer. Any questions from members? Representative Weber.
I just wondered if you currently keep direct statistics on what percentage of the Granted Advantage recipients are currently employed.
Our estimate is 65%, but we don't know whether they would meet the 100-hour requirement. Also, in terms of who would qualify for exemptions and so forth, we estimate about 44,000 individuals would either have to prove they're working or would have to seek an exemption based on current enrollment.
Thank you.
Other questions, Representative Kesselring?
Thank you, Mr. Chair. Thank you for taking my question. Again, I want to go back to the fiscal note, specifically the jobs that would need to be added. You mentioned that you looked at Georgia. Is there a difference in how you would need the requirement of the amount of people, the resources, by changing it specifically? And could you outline any of that?
You might want to take that question.
Sure. Thank you for the question. Karen Hebert, I'm the Director for the Division of Economic Stability for DHHS. So the level of effort to essentially operationalize this is certainly significant. The details are in the fiscal note that you can review, and we can always provide you with more information. So the personnel, I'm not so sure we can compare this current statute that we have on the books with what Georgia has implemented. We could certainly try to analyze that, but I can tell you that based on the analysis that we've done on the statute we have currently, this is the level of effort that is going to be needed. And I understand that there are certainly a number of components to the statute that require quite a lot of that effort. The number of exemptions, the verifications that have to come with the exemptions, the verifications that have to come with the work requirement, and the number of hours. So there is essentially an absolute need to have an appropriate number of staff who can process all of that and serve the clients who need to meet those requirements. We have the call center, of course, that we would want also to take place, which essentially operates or would operate as a tier 1 call center to be able to answer general questions, immediate needs, help people with gathering the right information and the right verifications and how they can do that, and how they also may be able to self-serve. So there are many components to it.
Follow-up.
Thank you. So I guess I'm going to rephrase the question in a different way.
Sorry.
What would you do differently based on current RSA law, based on what Georgia does? What would you do differently?
So I think, again, this is a policy matter, but a way to approach this would be to do it somewhat similar to Georgia, which is upon eligibility, assessed, and then annually. I think there's a lot of work doing it every single month, and then if a person misses it and has the opportunity to cure, we have to go back 90 days to see if they figured it out. I think The other thing I would also highlight here that didn't come up in the prior conversation when we were talking about TANF and other work requirements. What we were told when we successfully got the waiver last time was that someone can't be subject to more than one work requirement. So if you're subject to a TANF work requirement, you can't also be subject to this work requirement. There's only one work requirement that you can be subject to. But I think the main thing is, rather than having to do something, like 13 times and then reevaluate it, during those 13 times, and have to process all that, I think doing it on bookends is a reasonable approach that I think is in keeping with what states that are doing it are. They're learning from what happened with Arkansas and New Hampshire first time around in terms of some of the challenges. And Councilor Stephen also spoke to the litigation risk. There's litigation risk if you're not able to keep up with the work and people aren't should be eligible and don't get eligible because we can't keep up with the work. I'll point out that part of the budget that HB2 just passed in the House is going back to pre-pandemic eligibility requirements. That's increasing the workload in the department for Karen's team, the equivalent of 3 more months worth of work. The other thing that we want to make sure doesn't happen that happened in Georgia is that other people's eligibility, because the workforce couldn't keep up with that effort, it affected people getting eligibility timely for other services. They had to bring in contracted labor to help them get out of that. They're working their way through it. But I think there's lessons to be learned from what we did in terms of the cost and compliance activities, and there's lessons to be learned by what other states are doing. And again, our position isn't that we shouldn't have work requirements, that we should try to do one that has the right trade-offs, if you will.
Representative Kofal.
Thank you, Mr. Chairman, and thank you for taking my question. So Councilor Stevens spoke about sort of the benefits of sort of lifting people up out of poverty and the TANF program being the temporary assistance for needy families. So I'm just wondering, does the department take a position with respect to the value of productive work for those who are able to work, able-bodied people who are able to work, the value of that in promoting overall health and well-being? Does the department have a position on that question specifically?
Sure. Thank you for the question. So in the Division of Economic Stability, I have several programs that do support working families. So Child Care Scholarship, for example, the TANF program, SNAP employment and training. So we do have a number of programs to support working families because we do want them to become self-sufficient. We want them to become financially stable. So these are programs designed to be able to do that. So the question is really more policy. Will the program be designed to actually meet that particular outcome? And not just for the purposes of just we want people to work, to perhaps earn the benefit. We want people to actually gain that positive outcome from it. The TANF program, as Councilor Stephen brought up as an example of success, it is successful, but we're not tracking, or we only just started tracking the data to capture the number of people who are actually working as a result of the program. So right now we capture data with respect to participation rates. That's a different thing. So the number of people, the percentage of people participating in the employment program for TANF right now is at 68.9%. So that's successful for participating in the program. But what we want to be able to do is capture what's the outcome.
Anyone else? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. I have 2 quick questions. First, you mentioned that there are 3 bills currently going through the federal Congress with respect to work requirements. So, if we don't do this, does that put us in legal jeopardy? Or conversely, if we move too soon, does that put us in legal jeopardy because we don't know what the nature of these bills will be and we may have to pivot? So I'm just kind of wondering how you see that interplay. That's the first question. The second question is, from some of the questioning, there was concern about the fact with respect to the work waiver, we might not have another bite at the apple. I'm assuming that you guys would be heavily involved with developing the work requirement. Is there any reason that you can think of that there would be a radical departure in the development of that waiver from what we have had in the past? Thank you.
So I think if you could repeat the first question briefly, I think I have it.
The first question is, there's 3 bills.
Yeah, okay,
And so
gotcha.
if we don't go now, are we in jeopardy? Or because we don't know what these 3 bills are going to look like, do we want to wait until after? What is the interplay? Where are we in the least jeopardy?
So if you agree with our interpretation because there's an active statute on the books, I don't think there's a legal jeopardy issue in the short run because we could apply for the waiver and wait to get clearance on. I think the issue is the economics and meeting the time frame that's in the bill. I think, they're expecting us to submit the waiver by January now in terms of the amended Senate bill. I think the concern I have is, with all that we're being asked to do with the, generally in the department with basically a workforce hiring freeze largely, that our ability to do something that has no result because we are not consistent with what Congress is going to pass or otherwise. I do think that part of the consolidated reconciliation, the big $880 billion they're looking to get out of Medicaid, one of the major points of agreement among the legislators in Congress is that a work requirement should be there. And what I'm concerned about is, just from my workforce standpoint and Karen's workforce standpoint, is starting to implement something that is overridden by that. And I think we need clarification as to whether this statute, based on our opinion, that the statute is in effect, and this is what we'd have to submit, which we know has challenges and has higher costs.
And with respect to the language in the waiver, you think that would pretty much be the same?
I think that in terms of the waiver, we could, if we needed to submit this, it would largely be the same as what we submitted before. I do think that, based on court action on that waiver, I'm speculating here, that I think that there could be some adjustments to certain things based on, what other states are submitting. This would be much more stringent compared to what both Georgia has active and what I know Arkansas has submitted. That being said, I think there are options that we could do that as well that could incorporate a lot of what was done before, but also much less strenuous to implement.
One final follow-up.
Very quickly. So with all that being said, if you were to look at this July 1st date, is there a date with your resources that you feel is more realistic?
So as I understand it, the Senate amended it to January 1st to submit the waiver from July 1st, because if it was July 1st was the date we had to submit the waiver, we might not even have a bill signed into law by that date. So I think if we needed to resubmit what's in statute now, we could do that by January 1st.
Representative Lamontagne.
Thank you, Mr. Chair. So you said that about 65% of the people are already working.
To some degree, yes.
And then it looks to me that a lot of other people on granted advantage would qualify for the exemption. And there may be only like 10% of the people that may lose their coverage because they're not exempt and they're not able to work. But we might lose a lot of people who are already working, but because of the reporting requirements, they may lose coverage. So it seems like the net result is spending a lot of money for more administrative expense for everybody with very little impact on changing the number of people that are working. So I'm wondering what you think about that.
Yeah. So I guess in terms of the promoting people stepping up and growing out of being in a program like Medicaid or other support services, I think there's wisdom to that. The issue is how we go about it. What's the cost and resources to get that done, and do we get the result? I think we know, at least early on, that it was challenging. We even went door to door in Nashua and Manchester to help people understand what was up in front of them. And even doing that effort, it wasn't enough to see that we had a significant issue in front of us in terms of how to work through 16,000 individuals that weren't able to accomplish that. That being said, I'm not saying we're against doing a work requirement. It's we got to do one that I think that we have the resources to implement.
Representative Weber.
Thank you, and thank you for taking another question. I wanted to follow up with your statement that we have learned from the court cases in 2017 and that some changes might be necessary, but aren't we bound by the actual terms of the existing law until such time as we actually change the underlying substantive law?
If you read the statute, there's some flexibility there saying that we would need to bring those things back and be transparent. What couldn't be approved is, I believe, the way the statute reads along that point. In other words, I think when the legislature adopted the language that's in effect here, that there was an understanding that there may be some calibration of it as we go through the waiver process, and that our issue was to get as close to what the legislature asked and then report out on what we weren't able to get. And then we don't have any problem with reporting to any committee and sharing what our experience is and doing something up front. We'd rather have buy-in of the legislative body of what we're doing than to do something and then have to fix it.
Representative Tejas.
Thank you, Mr. Chairman, and thank you for taking my question. Councillor Stephen kind of mentioned, there's computer systems that exist and this can just be added on to what exists. And the fiscal note talks about how both New Heights and the MMIS really aren't going to be sufficient for what's needed. So can you explain that to us, please?
Sure. I think that what I would say there, it's not that they're not sufficient, it's that what we built and stopped updating because the court vacated the waiver and then CMS withdrew the waiver, that we didn't continue to spend money on something that we didn't think we could implement. But as we've built the system since 2018-19 period, we have to sync everything up so that it fits seamlessly. That's what the 1.7 million represents, of which 75% is expected to be federal money. That we need to make it work, but a lot of it is, again, because of our monthly reporting and having to upload documents, that we need to make sure that that information gets to Karen's eligibility workers so they can make the judgment. We just can't process all that in paper and expect to keep up.
Representative Hartnett.
Yeah, thank you, Chair. Thanks for taking the question. We've talked a lot about administering this law were it to come to be, the benefits of working, but just thinking purely now for Medicaid recipients, can you tell me what your top three worries would be for people on the street who are Medicaid beneficiaries?
So I guess number one would be is we don't want to implement a requirement where someone, say, for example, has a disability and they have trouble documenting what they're doing, and we end up closing them when it's because of their physical disability or mental disability or whatever disability that they can't navigate the program. That would be a concern, because also, if I'm remembering the statute right, it's not just a one-time exemption. I think it's annual that would have to happen. That's again another set of over and over again kind of things. So I think we don't want to interrupt someone who's in treatment, right, in terms of having them close. I think it's really we also don't want to be so consumed in administering the work requirement that we can't keep up with our other work, and that other people who aren't even part of this get affected by this in terms of the timeliness of all our other eligibility determinations. You can speak to our vacancy rate now and other.
Yeah, sure. So we have an integrated eligibility system, both the IT system and the staff. It's all the same staff who process eligibility for multiple programs. So they would still continue to process eligibility for Granted Advantage, but where there would be a significant additional workload of just the verifications that need to be reviewed in detail, approved, are they sufficient, as well as make determinations of the exemptions, and there are a number of them that would need to be renewed. Staff need to do that. We don't want to make sure that we're not hurting other people in other programs, because it's the only staff that we have to process that work. Right now, I have a 23% vacancy rate in this particular bureau for the field eligibility staff, and I'm also through the budget process. About 70 positions that so far have been unfunded in that field.
If I could add one more concern, is I think as, we also have in HB2 the 3% reduction from the House version, that in terms of providers who might lose compensation for people who closed unnecessarily, would be another concern in terms of whether they would agree to accept as many Medicaid individuals. So that would be how I'd answer that. Thank you.
My words, not yours. Your fear, again, moving back to the administrative end of this, that there could be real Medicaid casualties, pain, just because of a struggle to administer this program.
And that's why I think our fiscal note reflects what we feel is needed so that doesn't happen.
Thank you.
Any last questions? Oh, Representative Tejas.
Thank you, and thank you for taking my question. We've heard a lot about how working is good, and self-sufficiency is good, and trying to look at examples from around the country. Looks like these kinds of programs don't really result in a net increase in employment because of all the complications around, like what you've described with administering. I'm wondering if you can talk about how being healthy is a facilitator to being able to work, as opposed to, requiring work to be able to have health insurance. Can you talk about that flip,
Yes.
please?
In fact, I think that was built into how New Hampshire approached it, is that you wouldn't be denied eligibility up front, that, having your health conditions addressed so that you can participate, whether it be work or all the other types of options that are available, volunteering, what have you, that in fact, if you look in here, there's also a requirement that the MCOs facilitate a wellness visit, again, to prepare someone to be able to participate in an activity that would be compliant. I think those are good things that are built into New Hampshire's model here. I think that all I'm pointing out here is that, well, the thinking that went into all the exemptions and what have you, I think the legislators had a lot of policy input in that. The issue is in terms of it does take a lot to implement and to deal with it. And so the question, I think, in terms of healthcare status is, having coverage to deal with things that might be affecting you from working are an important part of what we include in our program as designed, and I think would be important to carry forward.
Representative Lucas.
Thank you, Mr. Chair, and thanks for taking my question. Just so I'm right about this, did you say earlier that the average tenure for being on the Medicaid Granted Advantage is a little less than a year?
Correct. That's the average. There are people who stay on longer than a year, but when you look at all the individuals, it is less than a year.
Follow up? So in creating this larger administrative structure, you're basically dealing with folks who may not even make it to 1 year for the reevaluation if it's only done at the initiation and that annually after that?
That's possible, but it's also possible that it's what enables them to get out into the workforce too, in terms of the year's worth of healthcare addressing needs. I think we got to the point in the implementation where we know people had challenges, but we really don't have any long-term view of what the outcomes would have been, and how that would have affected enrollment.
Thank you.
All right, I think that's it. Thank you.
And we'll send it through the materials like from here and a couple charts to
the committee, you mean?
Committee, yes.
Yeah, that'd be great.
Okay.
Thank
Thank
you
you
very
for your
much.
time. Appreciate that we got the extra few minutes here.
Sure, thank you. Also signed up to speak is Chris McCracken from Amoskeag Health.
Good afternoon. Thank you, Chairman McDonald, and thank you, members of the committee. Appreciate the opportunity to speak to you. My name is Chris McCracken, and I serve as the CEO at Amoskeag Health. We're a federally qualified health center located in Manchester, and we have the single greatest concentration among the federally qualified health centers of patients who are on Medicaid. It's a big proportion of the work that we do. And I was on board at the time that we had the work requirements in place that have been spoken about in the earlier parts of the presentations that you heard. So I remember exactly what it was like being on the provider end. And in addition to the budget that's being set aside to provide support so that the department can implement the standards, there is all of the work that then falls back to the providers of care to help the patients navigate this process, to provide all of the documentation that they need, to constantly have to submit documentation up to the system. For people that fall off of Medicaid as a result of either no longer qualifying under a work requirement standard, or for people that may not successfully complete this process, we are required to continue to provide their care, whether or not they continue to have Medicaid. And that's a good thing, right? We're supposed to be here to provide supports. But there was a 10% reduction in the number of people that were covered by Medicaid for us during the original implementation back in, I think, 2016-17. And we had to absorb those costs into our uncompensated care. As you can imagine, the federally qualified health centers, the mental health centers, many nonprofit agencies that serve these populations will feel the impact of potentially now a 3% cut to Medicaid reimbursement and a significant loss in areas of federal funds that may be changing as a result of some of what's going on a federal level, in addition to then having this additional burden and losing the dollars from the patients that we would have gotten that revenue from. It's if you look at that figure that 65% of the patients are already working that are receiving patients, sorry, it comes with the territory, the individuals that are already getting those benefits, and you think about 38% are estimated to be living with a disability, providing caretaking, whether it be an elder parent, whether it be a spouse that's sick, whether it be a child that may have special needs or may not be able to qualify for child care benefits. And then you've got individuals who are going to school. We're then potentially not getting any savings from making this cut to our general funds, as was earlier described by Henry Littman.
If we could start wrapping up, please.
Sure thing. But we've got those additional costs that are going to be incurred by the department. And we've got the loss of all of those funds when people fall off the market and we have to absorb those costs and the additional work that we have to do. So in the end, are we really moving the needle, whether it comes to either saving money or whether it comes to encouraging people to get back into the workforce? If they don't have a stable healthcare source, then and money to reimburse, to pay for medications, to get the tests and services that they need, they will be more likely to fall out of the workforce. So we're just concerned, and we want to make sure that from the provider perspective, that there's some information on that front and what we saw when we did implement this in the past. Thank you so much.
Thank you. Any questions? Seeing none, thank you.
Thank you.
Also signed up to speak is Raymond Burke from the New Hampshire Legal Assistance. You've asked for 5 minutes, sir. If you could keep it to 3, please.
Understood. Thank you, Mr. Chairman and members of the committee. I will try to be brief, and please bear with me. I'm going to jump around a bit given the time and some of the questions I heard. I'll just note, if I don't get to it, I'm happy to provide later or in response to questions. I do have some data from Georgia in particular and some other states, not just around Medicaid work requirements, but the impact of work requirements and other programs again, happy to answer questions or share that after. But for the record, my name is Raymond Burke. I'm an attorney with New Hampshire Legal Assistance, and I'm here today to provide this testimony in opposition to this bill. Legal Assistance is a statewide nonprofit law firm. Our attorneys and paralegals represent low-income clients throughout the state regarding various civil legal issues, including on behalf of clients seeking to access health insurance through the Medicaid programs. Based on our experience representing our clients, and in particular with regard to the last time New Hampshire tried to implement work requirements, we opposed this bill and encouraged the committee to recommend that it be inexpedient to legislate. We believe this bill, in short, is premature and risks wasting resources. As you know, as you've heard today, there's been some conversation, or there's a lot of conversation going on at the national level about potential changes to Medicaid, both the eligibility requirements and the funding structure. Our position right now is that under the current law that exists, New Hampshire cannot implement work requirements. As you heard, we have a statute on the books that already dictates what the waiver should look like, what those work requirements should look like. And as you already heard, the courts struck those down. The law hasn't changed since then. So if the state were to move forward with this, absent a change in federal law, the state would be risking, litigation, as was discussed, under very similar, if not the same, claims that were brought previously. I can talk more about the Georgia work requirements and the litigation that was there, but given the time, I'm just going to say that briefly that there are significant differences in terms of the facts on the ground there and the legal posture of the case that are distinct from what happened with the New Hampshire litigation and what would happen under the current law should New Hampshire seek to pursue the work requirements again without a change. There's also other reasons why we think it would be more prudent to wait and see what happens on the federal level. There's a couple of different proposals, as you heard, being discussed in Congress. One of them is to reduce the percentage of federal matching dollars that would be issued to states to run the Medicaid program. Another is to block grant the Medicaid funding. Well, in New Hampshire, we have what are known as trigger laws in our session laws. If Congress were to pursue either of those options, the Granted Advantage program under current New Hampshire law would end. So if we go forward with this and spend the time trying to do this, and then Congress ultimately passes either of those two options, it will be for naught because Granted Advantage will cease to exist. So for those reasons, and there's more I could provide if you have questions, but we believe the best course to avoid any risk of wasting time and resources that we should wait to see what happens on that federal level, and then the legislature could amend the statute that's on the books and direct the department to respond based on whatever those changes may be at the time.
Thank you. Any questions? Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. You mentioned that Georgia work requirements are significantly different, and we heard that New Hampshire was trying to ask for 100 hours per month, and other states are asking for less. But I also wonder about those 11 items on the book. So it's not just working, it's also volunteering, or it could be participating in mental health treatment. So having so many different options, is it benefit or is it makes it more complicated, and what Georgia did differently?
Well, I think to be honest with you, I'm not very familiar with the exemptions in the Georgia's waiver. I would have to look at those more closely. But what I can say in response to your question is, given all of the exemptions that we have in current law that you just referenced, you heard testimony from the department. We know that it was estimated about 16,000 people were still going to lose coverage in New Hampshire had the courts not stopped the implementation of the work requirement previously. So despite the best efforts, I think, from the department, and you know, in other states, we see this time and again, that even though there are exemptions included, the experience shows that those exemptions often fail to prevent eligible people from losing coverage. So you see it time again in other states that people who lose coverage include people who are already working, people with disabilities, caregivers, and older adults. And oftentimes it's possible that many of those people would in fact meet one of those exemptions, but because of all the red tape and administrative burden that goes with trying to verify that, they fall through the cracks and lose coverage nonetheless. That's what we saw in Arkansas back in 2017 to 2019. And what we know is there's been a lot of discussion today about the statistics, and you heard a little bit about who's working. Just to add to that, the national data, I couldn't find state-specific data, but the national data shows that when you look at the Medicaid expansion population who are not receiving a disability-based benefit like Supplemental Security Income, SSI, 64% of the adults enrolled in that Medicaid are working full-time or part-time. That actually tracks what we heard from the department a little while ago in terms of what they see. But in addition to that, at the national level, another 10% of adults are disabled or ill, another 7% are students, and another 12% are not in the formal workforce because they are caregivers. Those numbers add up to 92% of the population. So on a national level, these work requirements are really targeting a small sliver of the population, about 8%. But the problem is that the work requirements don't just impact those 8%. Everyone who receives the coverage has to comply with them, has to verify either that they're meeting the community engagement requirements, the number of hours, and what constitutes work or volunteer efforts, or that they meet an exemption. And so again, the exemptions, despite best efforts, are not a safeguard to preventing eligible people from losing coverage. And from our position, and in terms of, you know, this goes back to why the court struck this down. Medicaid is ultimately health insurance. Its main objective is to provide medical assistance. It's not an employment program. Yeah, so while I can't speak specifically to how the exemptions in Georgia compare to New Hampshire's and what we have in current law, I think there are still some concerns whatever the exemptions look like. It's just a reality. You're going to lose. You're not going to be able to capture everyone. People are going to lose coverage.
Representative McLean, did you have your hand up?
Just super quick because we've got a full room. With respect to the legal jeopardy, I'm a little bit confused because I thought Director Lippman said, I think we're okay from a legal perspective. It's the time perspective, the resource perspective that he was really worried about, and he was looking, you know, for the January timeframe. With respect to the 5 or 6 states that have brought in work requirements recently for Councilor Stevens' testimony, are any of them being sued other than Georgia?
So the Georgia lawsuit's already over, so I could speak to that if you have questions. As of this moment, I'm not aware that any litigation has been filed, but I will say it's also very early in the process. As far as I know, you know, maybe the department could speak better. I think to look this up today, but I'm not sure how many of those requests have actually been approved yet. So it's still very early. I mean, you know, in New Hampshire, litigation wasn't brought on behalf of our clients until after the waiver was filed and the approval. The litigation was ultimately challenging the approval and that it was inconsistent with the federal Medicaid statute.
Okay, so early days. Thank you.
Okay, thank you. Anyone else? Seeing no one else, thank you.
Thank you.
Also signed up to speak is former Representative Jerry Kinnaird.
Thank you very much. And for the record, yes, my name is Jerry Kinnaird, former state rep and also a physician. SB 313 in 2018 imposed a work requirement for Medicaid, but the implementation was a disaster. In the first month, for which participants had to document their hours, only about 8,000 of the 25,000 people subject to the requirements were able to comply, leaving about 17,000 that were going to lose coverage. Actually, I've just been corrected by Mr. Lippman that it's actually 16. In any case, in order that 17,000 didn't lose coverage, Governor Sununu halted the requirement. He recognized that it could not be successfully implemented. But a large amount of money was already spent trying to notify the public, including sending state employees door to door. As per the fiscal note, in the fiscal year 2019, the department expended $4.4 million in total funds to implement this failed community engagement requirement before pulling the plug. And the fiscal note on this bill also estimates that the cost of the amendment for the fiscal years 26 and 27 would be about, cost of the bill, would be about $5 million. That's $14,000 a day for a policy that previously failed. Arkansas had a similar experience in about 2019 when they tried to implement their work requirement, had a loss of coverage of about 25% of people, and a study of that debacle demonstrated that the loss of Medicaid coverage was accompanied by a significant increase in the percentage of adults who were uninsured. And they found no significant change in employment or hours worked. They found that implementation of the policy was plagued by confusion, lack of awareness by the population, and enrollee difficulty reporting their status, secondary to lack of internet access. A study by the Economic Policy Institute in 2025 demonstrated that the main barriers to work are economic conditions that are beyond the enrollee's control and unstable employment situations. Many jobs available to low-income adults are characterized by irregular and unpredictable scheduling practices that make consistent work difficult to achieve. In our area, I'm up in the north in the Ocean Valley, we have a lot of seasonal workers. They may snowplow and run ski lifts in the winter, landscape in the summer, but they may have a gap, so this monthly thing doesn't work very well for them. Communication with enrollees and compliance can also be very difficult. People with unstable housing may not have a mailing address or a computer to document their work. Monthly documentation would be particularly difficult. The important part, too, is the loss of health care coverage actually makes it more difficult for people to work. Consider an asthma sufferer who may have difficulty maintaining a steady work schedule when they lack health insurance to keep their asthma under control. They keep having attacks. They're working as a waitress. They keep having to miss work. Throwing people off Medicaid will not save money. Costs will go up because it's cheaper to keep that asthma sufferer under control than to treat him with an attack. And with more uninsured people, the cost of treating uninsured patients will rise, putting more stress on our hospitals. I'll wrap up. Health insurance is a fundamental necessity, not a handout. It's a safety net in case of injury or illness, and Medicaid work requirements are more likely to result in loss of coverage by those already working than an increase in the hours worked. And the studies have demonstrated that. So there's really no reason to repeat an already failed policy and spend a lot of money doing it. This bill should be ITL. Thank you, and I'd be happy to take any questions because I was there for this stuff in 2018.
Any questions? Seeing none. Thank you.
Thank you.
Also signed up to speak is Jake Berry from New Futures.
Good afternoon, Mr. Chairman, honorable members of the committee. My name is Jake Berry. I am the Vice President of Policy at New Futures. We're a nonpartisan, nonprofit health policy and advocacy organization. We've been working for more than 25 years to increase access to affordable and quality health care in our state. We are the home of New Hampshire Kids Count, and we lead the policy work for the New Hampshire Alliance for Healthy Aging. All this to say, we work to support health and well-being across the lifetime, and Medicaid is a key support for all of the age groups that we intend to serve. I do want to reinforce a few of the points that have been made today. Certainly we all agree that where the work is fundamental to health and well-being, and that's exactly with the intentionally Medicaid expansion program and the way that it works. As you have heard, nearly 2/3 of the people on Medicaid expansion are already working. Those who are not working are, for many of them, for most of them, it's because they are experiencing health or other challenges that make it hard or if not impossible for them to work. All work requirements like those that are cited in this bill do is make it is have people lose access to their health insurance, make it harder for them to return to work, and ultimately save the state money. A few notes, as we said last time we tried this in 2019, we were on pace to lose 16,000 people were on pace to lose coverage. For reference, that is 2/3 of the people who were eligible for work requirements at the time. Meanwhile, the state was going to spend $4.5 million to implement this program, which again did nothing but sacrifice people's health insurance coverage. That is mirrored or paralleled in what we have seen in other states. There's been a lot of talk of Arkansas and Georgia here today. In 2019, when Arkansas tried to implement, 16,000 people were on pace to lose coverage. In Georgia, which is currently the only state with an active work requirement on file, the state has spent $24 million to implement this program, to administer this program. There are 5,100 people that were enrolled in Medicaid expansion as of last October. That is out of 175,000 eligible people. 5,100 out of 175,000 people who were on the program out of the total eligible population. That's about 2.9% of the eligible population. And again, they spent $24 million to administer the program. So again, we absolutely agree that work is critical to health and well-being. That's why Medicaid expansion is in place. That's the way it's working. Adding work requirements like this would just increase the costs and decrease access to health insurance for people in need. And I'm happy to take any questions.
Thank you. Representative Polazov.
Thank you, Mr. Chair, and thank you for giving us some data and taking my question. I'm a little bit confused. So in previous testimony, we heard that New Hampshire was about to lose too many, 17,000 people were about to lose coverage, but you're saying in another state it's only 2% who are losing coverage. So why New Hampshire was about to lose so much and other state is losing so little?
Sure. I think, as you heard from Mr. Lippman in the department earlier this afternoon, I think that they had a great, let me be clear. The majority of people who were on pace to lose coverage, it was not necessarily because they were not working. It was not necessarily because they were not meeting the hours requirements. It's because they had challenges in reporting that. They, as Dr. Knirk indicated earlier, some people did not have internet access, not able to work the computer program. It really is the administrative burden of reporting. We went to great lengths to try to contact people to inform them about the work requirement and be able to help them to meet the reporting standards. We were unable to do so, and about, again, 2/3 of the people who were being subject to the work requirement were on pace to lose coverage at that time. Again, I do want to come back to Georgia when I talk about 3%. Georgia is the only state currently, at least as of several weeks ago, that has a work requirement currently in place. On that program, there are 5,100 people enrolled on the program out of 175,000 people that are who are eligible. Again, that is about 3% of the eligible population, and it is widely believed that the reporting barriers and the work requirement standards are a main contributor as to why people are not able to access that program. And again, meanwhile, the state is spending $24 million to administer it.
Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So what happened to the balance of that 175,000 then? Did the state drop them in Georgia? Do you know what happened?
So my understanding, the state didn't drop them because they were never enrolled in the first place. They were, this is of the population who, would be eligible for this health insurance coverage. But and I should say, Georgia has been unrolling the program over the last several years. So they did not lose coverage. They were just never enrolled in the first place. But they have, in part because of these administrative hurdles, they have not been able to enroll and access health insurance coverage.
Representative Weber.
So am I to conclude from your remarks that all those other states that we heard about have applied for a waiver but have not yet, either they haven't received the waiver or they have not yet stood up their program, so we don't have any data coming from those states? Is that correct?
That's correct. And we should note the prior, the prior administration in the White House and federal courts at the time were not accepting, were not approving these requests. So they are just starting to come in now. And yes, that's why there's only this one program that's currently stood up.
And could I have a follow-up? So I wanted to explore a little bit more, because I heard it differently both times you said it, that 3% or the 5,100 enrollees in Georgia.
Yes.
Are they enrollees into a new program that started since this administration took over? But then I thought I heard you say they've been enrolling people for several years. And I'm just trying to figure out if you know what the time frame was there, because 5,100 out of 175,000 or 3% is a very small percentage of an eligible population.
A very small number. Yes, no, correct. I do not believe I believe they had started to unroll the program before the change in administration. I don't know the mechanics of how that came about. I know that they have been giving launch to the program over the last year or two. So it is a new program, but I would have to do a little more research and get back to you to learn more about the specifics.
If you don't know, it's fine.
Sure.
Okay, I guess we're all set. Thank you.
Thank you very much.
Also signed up to speak, Dan Wago, I guess it is, TLC Recovery Programs. I'm probably not pronouncing your last name right.
It's Wargo, thank you.
Wargo, I'm sorry. And again, sir, if you could keep it to 3 minutes, please.
Yep. Thank you. Thank you for having me. My name is Dan Wargo. I am the Director of TLC Recovery Programs. I'm here sharing the perspective on treatment and recovery services. I oversee one of the larger recovery centers in New Hampshire. We have recovery centers in Claremont and Lebanon. As you probably know, we've made leaps and bounds over the years as far as helping people struggling with substance use disorder to get the help and the support they need to move beyond their disorder into recovery, into health and wellness. One of the key elements that I've seen that has made that possible and made so much progress is accessibility. When dealing with substance use disorder, and I've worked with hundreds of people, and we serve hundreds of people every year, I observe on a regular basis that people, when they are ready, the quicker that help can be offered and the quicker they have access to that help, the more likely they are going to be successful in following through with that help. One of my biggest concerns with this bill is that it could potentially impede upon the accessibility that people with substance use disorder currently have to get the help that they need when they're ready to do so. A couple of the worries that I have is if somebody already has Medicaid and they have a relapse or recurrence, which isn't uncommon. During that process, they probably won't be reporting as much as they would be if they're in recovery, or they might just fall off the map completely. But then when they want to get back into recovery, I imagine there'd be a whole nother process they'd have to do in order to get the access they need to be able to get into treatment or get into whatever treatment services they need to be successful. Another worry that I have is that some people coming into recovery, they can come out of the gate and they can get right into the workforce. It's very common, but then there's other people where they have a lot of fires to put out, for lack of a better word. They need higher, more robust treatment, which involves, IOPs, groups, regular support. and getting into the workforce quickly can actually be detrimental to their early recovery. And some people, it just takes a few more months than others to get back into the workforce. And then the other worry that I have is just missed reporting and paperwork. As it's been said, there isn't a lot of information on what that would look like, but I do worry that if somebody did not have the documentation in time, or there are scenarios preventing it from happening in a timely fashion, would that mean that they would lose the treatment, the medications, the outpatient, and the community support that is covered by Medicaid to get those services? And then just to end, I'm unsure the details of these work requirements, but I can say with certainty that any time a process that is simple and effective is compromised, it complicates the process and has a direct negative impact on the process that once upon a time worked so well. I'm asking that you all reconsider the bill and the ramifications it can cause with those experiencing substance use and those in recovery. We've done such a great job as a state and will continue to do so if we maintain the foundations for people's health, growth, and healing.
Thank you. Representative Polazov.
Thank you, Mr. Chair, and thank you for your testimony and taking my question. So if I understood, your main concern is that people, their recovery is covered, and if they lose coverage, because of work requirements, they won't be able to be treated. But the way I read the underlying chapter, these work requirements, including item number 12, participation in substance use disorder treatment or recovery activities and or mental health treatment. So would you be more approachable for this bill if the underlying work requirements include, so if people can include treatments that you provide into those 100 hours per month, and also would you be able to help people document it if needed, if they would need to be documented that they spent 100 hours in your center to be eligible for Granite Advantage Health?
Yes, thank you for the question. From what I read from the bill as it was worked through earlier, that there was conversations about exemptions for people to get into treatment for substance use, which is great. I guess my concern would be after somebody was to get into treatment, come back out, get their Medicaid, turn back on, and then if they were to relapse, and then lose that Medicaid coverage during that time because they're not reporting, what would it take in order for them to get that turned back on to get access to treatment when they are ready to do so? And I guess I highlight that because the window of opportunity, as I like to call it, for people when they're ready to get help can sometimes be extremely narrow. Some people, it could be a matter of minutes between I want help and until the illness can kick back in, and then they can be just deciding to not get help. The quicker that we have the ability to meet them where they're at, to get them the help that they need when they're requesting it, the more likely that they're going to proceed forward and be successful. But the more barriers we put in front of that, the less likely that they are to follow through with that.
Representative Weber.
Thank you, and thank you for taking my question. Am I right in thinking also, in addition to that it isn't an either or? People don't come with either physical ailments or substance abuse. Many people have both. And if they lose their coverage because they have not participated this month in the substance abuse aspect, they're not only losing the coverage for their substance abuse issues, they're also losing whatever coverage for whatever underlying issues, diabetes, asthma, whatever else that they might be needing. And do you have any idea, if you know, how many of your clientele also have underlying physical issues for which they need the medical coverage?
Yes, great question. Thank you. I don't know the exact numbers, but I would say that there's a noticeable amount of people that get services with us that also have physical disabilities and rely on Medicaid and Medicaid expansion to get assistance for those things. I also want to point out too that a lot of the people that we serve do get into the workforce, and many of them are working. But what happens oftentimes is when people are getting into recovery, I mean, they're not starting necessarily ground zero. Often they're in the negatives, and there's so many things that they have to get in order in their lives, and so many things that they, need to pick up where they left off, and pieces to put back together. I worry that if we start adding restrictions to health benefits, that we're just putting one more thing in front of them that they have to work through, when their priority should be recovery and abstaining from substances. And then, getting the assistance that they need and the accessibility they need to make that as easy as possible, because it's hard enough on its own to be successful in doing that.
Okay, I think we're all set. Thank you.
All right, thank you.
Also signed up to speak is Sam Hawkins from NAMI of New Hampshire.
Good afternoon. Thank you for the opportunity to testify today. For the record, my name is Sam Hawkins. I represent NAMI New Hampshire, the National Alliance on Mental Illness, here today in opposition of Senate Bill 134. To begin, I want to highlight that Medicaid is the largest payer for mental health and substance use services in the country, providing coverage to more than 1 in 4 American adults with a serious mental illness. We have grave concerns that enforcing work requirements would have a serious impact on access to care, increase uncompensated care, and cost the state a significant amount of money without increasing employment rates. I do again want to emphasize that Medicaid is already a bridge in supporting employment by providing access to the treatment that enables people to work. Further, as you've heard, research indicates that many Medicaid enrollees are already working, and then you have that other chunk to which exemptions would apply, and just that very small chunk that are being targeted by work requirements. So we know that having a serious mental illness can make it harder to get and stay employed already. Add on to that significant burden of working or keeping up with treatment, the significant burden of keeping up with reporting requirements, we expect that many people may lose coverage or just be discouraged from pursuing it altogether. According to KFF, as you've heard during Arkansas's brief waiver implementation, more than 18,000 people lost coverage. What's really important to note there is that few people actually utilize the safeguards intended to protect coverage. There was difficulty with reporting that presented barriers to people retaining their coverage, and there's research indicating that enrollees in Arkansas were unaware of or confused by the work and reporting requirements, which essentially leads to no increased incentive to work. With all of this in mind, we expect to see that individuals who would be able and willing to work, thanks to the treatment that Medicaid provides, may actually end up losing their coverage, leading to a worsening of their condition and further increasing the likelihood that they will not be working, they will not be engaging with treatment, and they will not be engaging with their community. For these reasons, we believe that enforcing work requirements is likely to decrease coverage, leading to adverse outcomes, increasing uncompensated care, and increasing the cost on the state without meaningfully increasing employment or community engagement. As such, we urge the committee to please vote ITL for Senate Bill 134. I'd be happy to take any questions.
Thank you. Representative McLean and then Representative Palazzo.
Yes, thank you, Mr. Chairman. Thank you for taking my question. You may not know the answer to this, and maybe some of the people who testified earlier would, but I ask it just because, you're talking about, the difficulties of the reporting requirements. And, if you looked at the way the employment waivers were structured in 2017, you have a requirement to report every month how much you worked. But let's say you were going for an exemption. Is that just a one-time report thing? I'm blind, so I can't work or whatever. Therefore, I'm is done. I've reported it that one time, and I don't need to do that every month. So it's only the working that has to be reported every month, but the exemption itself only has to be applied for the one time. Am I correct in that understanding?
Thank you for your question. I haven't reviewed the statute all that recently. However, based off the testimony of earlier speakers, it sounded like you did have to re-up that exemption. Maybe not monthly, but you did have to re-up that. Thank you.
Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. So similar to what I asked previous speaker, yeah, I am confused if your problem with underlying RSA 126, which is a basis for this suggested waiver, or because, yeah, would you be more amendable if we rename this bill from work requirements to mental health treatment requirements? Because in RSA 126 AA, those 100 hours could be completely qualified by participation in substance use disorder treatment or recovery activities and or mental health treatment. So as an organization who deals with mental health, I think you can help people with qualify for underlying statute for those 100 hours. It's not just work related. What your thought on this?
Thank you very much for the question. I would be very concerned that enrollees may not be aware that treatment would apply to the hour requirement, and as such would be dealing with the burden of going through treatment on top of trying to hit all those hours. I mean, we've seen in other states that people weren't aware of safeguards, they weren't aware of exemptions. I expect we would also see that here. And also I would just, I'm not sure I would see that hour requirement as an actual incentive to access treatment. I think people want to get better. They're going to try to get better with the coverage that Medicaid already provides. I don't think an hour requirement is going to provide further incentive, just further jeopardy. Thank you.
Representative Weber.
Thank you. And if we're talking about mental health treatment, and we're talking about a 25-hour-a-week work requirement or equivalent requirement, am I not right in thinking that unless you're actually hospitalized, you're probably not going to get that much mental health treatment in the course of a week? You probably have, you know, 1 or 2 sessions with a therapist and then maybe some group work, but it wouldn't come... The normal outpatient treatment wouldn't come anywhere close to the 25 hours, would it?
Yeah, thank you for your question. I'm tiptoeing into speculation a little bit here, but I would say with the granted advantage population, they're probably not in those highly intensive services where they would be seeing tens of hours of treatment a week. You're probably right that it would be more a couple hours a week, some individual work, some group work. So they would, they're not likely not going to be able to hit those 100 hours a month just by accessing treatment.
Right.
Thank you.
Okay, thank you.
Okay. Seeing no one else? Okay, thank you.
Thank you very much.
Also signed up to speak is Sarah Gagnon from Community Mental Health Centers.
Hi, thank you everyone. Thank you for the opportunity and for the House Committee to allow me to submit my testimony in opposition to SB 134. My name is Sarah Gagnon. I'm the Vice President of Clinical Operations for Riverbend Community Mental Health. I have worked in a community mental health center for about 20 years. Several of those years was as a case manager and a clinician actually supporting people in applying for Medicaid and keeping their Medicaid benefits. I'm also here to represent all the community mental health centers who serve over 54,000 clients, which are adults and children with severe persistent mental illnesses throughout the state. Riverbend Community Mental Health is right down the street here in Concord, serves more than 6,000 clients annually that have mental health and substance misuse issues. Our clients have New Hampshire Medicaid as their primary insurance to support all mental health services. A foundational philosophy community mental health supports is that meaningful employment opportunities support long-term and sustained recovery for those suffering from severe persistent mental health. Every mental health center in the state is tasked to support their clients in finding employment and keeping employment. Although our clients would meet the proposed exclusionary criteria for the working requirement for Medicaid, there is still a substantial risk to mandating employment for Medicaid, which is why we are opposing this. Our folks are dependent on New Hampshire Medicaid to stay out of the hospital. They need medication to stay out of the hospital. They need case management and therapy to stay out of the hospital. They will lose their coverage due to the reauthorization process to prove employment and to meet the exemption. For anyone who has been on Medicaid or has helped someone apply for Medicaid, and I myself as a case manager has helped hundreds of people apply for Medicaid and stay on Medicaid. And when you're doing that with people with severe and persistent mental illness that have a hard time thinking clearly, getting out of bed, too anxious to hold a pen, and you have to say, today's session, sorry, we're not going to be able to talk about your family that you want to reconnect with or the medications that you need. I need you to focus on completing this paperwork to prove that you need to meet a work exemption. That is extremely difficult for several of our clients that we support. Proving eligibility for exemption often requires the documentation, doctor evaluations, and navigating a complicated system. This affects a population who already faces challenges regarding housing and transportation and simply just thinking clearly on a daily basis. Adding an additional administrative burden to clients and to the Department of Health and Human Services will only result in people losing their insurance. It will lead to an unintentional disenrollment due to a complicated and lengthy reporting system that is overwhelming and inaccessible for clients with severe mental illness. People need to be mentally and physically stable in order to work. Thank you. I'll wrap up. Making New Hampshire Medicaid harder to obtain will put thousands of our highest risk granted staters in jeopardy of losing their insurance. The system-wide effects are massive, which will increase expense for the state with police force and sickness and hospitalization. Thank you. I'm happy to take any questions.
Thank you. Any questions? Seeing none. Thank you. Also signed up to speak is Nancy Vaughn from the American Heart Association.
Good afternoon. Thank you for this opportunity to testify on this issue. For the record, I am Nancy Vaughn, Government Relations Director for the American Heart Association. And I am here to provide comments in opposition to establishing a work and community engagement reporting requirement as a condition of the Grant Advantage eligibility. The American Heart Association's main concerns, as I've outlined in my written testimony, and I will try not to touch on all of it verbally, but just what we have found when examining programs with work requirements. The Congressional Budget Office found that even when work requirements increase employment, it was only for a short-term effect, with some programs showing no increase at all. And that work requirement programs are costly to administer and burdensome for participants, staff, and government agencies, as you have heard before from people before me. The people who do lose their coverage are mostly contending with physical and mental health challenges and caregiving responsibilities that work requirements will not address. Work and community engagement compliance may cause disruption in coverage and create barriers to medical care for chronic conditions. Individuals with cardiovascular disease often experience lapses in employment due to their condition, or may have been directed by a physician to take time away from work as part of their treatment or recovery. And as you've heard before, how the reporting goes or has in the past, is that has been a difficult thing for people and even for healthcare providers to provide that verification. Health insurance is, as you can well imagine, is an important tool in the fight against heart disease. It's a leading cause of death in New Hampshire. Conditions such as high cholesterol and high blood pressure can be controlled if detected and treated early and prevent costly heart attacks and strokes. So we do not want to see disruptions in the care that people have in order to, they have risk factors, but they need to prevent the outcome of those risk factors. Should people lose their Medicaid coverage, these costs could increase uncompensated care. That will certainly overwhelm our healthcare systems, especially in the rural areas, and will impact all Granite Staters in the form of raised health insurance premiums. To prevent and treat heart disease and stroke, it's critically important to ensure that everyone in New Hampshire has access to high-quality care. This includes the hardworking people struggling to support themselves and their families, but whose incomes leave private health insurance premiums out of reach. Medicaid is a lifeline for people with low incomes. In conclusion, the American Heart Association urges you to oppose passage of Senate Bill 134. And I am happy to try to answer any questions to the best of my ability.
Perfect timing. Any questions? I'm seeing no questions. Thank you.
Thank you very much.
Also signed up to speak is Kristen Evans from Able, New Hampshire.
Honorable Chair and committee members, thank you for the opportunity to testify in opposition of Senate Bill 134. For the record, my name is Kristen Evans, and I am the Director of Policy for ABLE New Hampshire. And ABLE is a disability justice organization, and we fight for the civil and human rights of people with disabilities in New Hampshire. This bill is not just misguided, it is a direct threat to the health, safety, and dignity to people with disabilities across New Hampshire. ABLE New Hampshire has heard directly from people with intellectual and developmental disabilities, people with mental health conditions, and people with physical disabilities who are terrified of losing their Medicaid. This fear is not hypothetical. This bill claims it will not create new positions or allocate new funding, yet it anticipates $5 million in expenditures. Where will these resources come from? How many people with disabilities, how will people with disabilities be notified, supported, and exempted appropriately? Who will assist those who cannot navigate complex bureaucratic systems? The answers are not in the text of this bill, and that absence is negligent. This bill will not result in increased employment. It will not reduce poverty. What it will do is punish people with disabilities for the barriers they face, strip away their access to health care, and undermine the very values of equity and inclusion that the state claims to uphold. This policy asks more from the recipient, the system, DHHS staff, and funds for a program that already shows to be used temporarily. This committee has a choice. You can reject SB 134 and affirm that New Hampshire believes in protecting and empowering its disabled residents, or you can move forward with legislation that has already caused measurable harm in other states, knowingly putting people with disabilities at risk. I urge this committee to lead with evidence, compassion, and courage, not to follow failed policies that punish our most vulnerable. Thank you.
Thank you. Any questions? Seeing no questions, thank you. Also signed up to speak is Brian Harlow. Did Mr. Harlow leave? Okay. No one else has signed up to testify. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on SB 243 FN and open the public hearing on 243 FN. It's my understanding that Senator Ricciardi is not able to be with us, and Max Taylor will be sitting in for her. Okay, Mr. Taylor, the floor is yours.
Good afternoon, Mr. Chairman and members of the committee. For the record, my name is Max Taylor, and I'm the legislative aide to Senator Ricciardi. I'm here today on her behalf to introduce Senate Bill 243 FN relative to the Child Care Scholarship Program, an essential resource that helps families access safe, affordable, and high-quality child care. SB 243 FN modernizes key components of the scholarship program to better reflect the realities faced by working parents and child care providers in New Hampshire. Childcare is more than a convenience. It is a foundational to economic participation, child development, and community stability. When access to childcare is delayed or denied due to red tape, our families and workforce suffer. Many parents face a stressful balancing act when starting a new job. They need care to work, but must wait for their scholarship application to be approved before they can afford care. If that approval is delayed, they risk losing both the job and the childcare slot. SB 243 FN allows eligible families to receive up to 60 days of scholarship funding while their application is pending, bridging that critical gap. New federal guidance supports this change, and it's a practical, cost-effective way to keep families in the workforce and children in safe care. SB 243 FN also commissions a study on the application process itself to ensure that families can access the program without undue barriers. Currently, providers must deliver care before being reimbursed for scholarship-funded children. This creates financial strain and discourages participation in the program. SB 243 FN establishes prospective payments, allowing providers to receive scholarship funds at the beginning of each service period, just as they do with private paying families. This will increase provider participation, improve financial stability, and bring New Hampshire into alignment with federal best practices. Although New Hampshire now uses an enrollment-based payment model, providers are still required to report detailed daily arrival and departure times for each child. This creates unnecessary data entry work without improving program accuracy. SB 243 FN eliminates this outdated requirement and lets providers focus on care, not paperwork. Together, these reforms reduce red tape, expand access for families, and create a more sustainable and appealing program for providers. They also ensure that New Hampshire remains eligible for federal matching funds and positions our state as a leader in pragmatic, family-centered policy. In short, SB 243 FN is about removing obstacles not just for families and providers, but for the long-term strength of our workforce and economy. With that, thank you for your time, and I will respectfully ask that you direct your questions to the experts sitting behind me. Thank you.
Great, thank you. Also signed up to speak are Brian Clark and Karen Hebert from the Department of Health and Human Services.
The big chair. Good afternoon. I'm Karen Hebert, Director for the Division of Economic Stability for DHHS.
I'm Brian Clark, General Counsel for the Division of Economic Stability.
So I understand that there are a number of the bills that went through the Senate that included appropriations with the were tabled with the intent of trying to address them in the budget process, but there were a couple, including this one, that were not included in that that move. So I do have an amendment to offer to the committee, specifically to include the appropriation, and I can either provide that now or at the end of the hearing.
You can include it in your testimony.
Okay. So essentially, the department, as the previous gentleman just mentioned, has for the last 2 years engaged in enrollment-based payment methods for the child care scholarship to the child care providers. This essentially is a change from the previous method that we used, which was attendance-based payment method. So the system had been designed for the previous years to have the providers report to us the hourly attendance. They're actually required by federal rule to report hourly attendance regardless of the payment method that we use. So that we do have system changes that would be necessary for accommodating that. We're more than happy to make changes that make it easier for providers. So we do agree with that. We would like to be able to make that change, but it will require us creating a different system and method in order for them to report the hourly attendance of children in a different way. But if it makes the billing process easier for them, then that is great. The bill also refers to the implementation of changing the payment method to pay providers prospectively. Right now, we pay them after the service is provided. So that is actually something that we are required to do now federally. And the bill also calls for a presumptive eligibility pilot. Presumptive eligibility in childcare is not federally required. It is an option. We don't have enough data to determine really what is the value of presumptive eligibility and how great of a value does that have for families and or providers. So the pilot would enable us to be able to test that and collect that particular data. So the appropriation that we are including in the amendment is a total of $171,600 for the biennium ending June of 27, essentially to make the necessary system changes for the changes to the billing system and the changes to implement a presumptive eligibility pilot. The other part of the bill refers to an application process study. The department is always interested in trying to make our application processes more simplified for people. So this study, essentially, we would be able to really take a look at an analysis of what are families actually experiencing in that particular process when they apply for childcare. We have an integrated eligibility system, and the application for any program that people apply for it includes multiple programs. We try to make it easier for people because most people do apply for multiple programs. But if somebody wants to just apply for childcare alone, they're apparently having some complications because it's very confusing as to what's actually required if they just want to apply for childcare. So the study would essentially be able to get a lot greater feedback and document that about what is people's experience so that we can make the right changes when it comes time to make changes. So the amendment also includes a sum of $200,000 for the biennium, again, ending June of 27, specifically to conduct that particular study. Do anything to that?
All set? Okay. You're ahead of schedule. Any questions?
No.
Representative Mazur.
Yeah, thank you, Mr. Chair. Thank you for taking my question. So you alluded to an amendment that you have, and you also mentioned an appropriation.
Yes.
In that amendment, can you repeat that? Was that 200,000 just for committees to be set up?
The 200,000 is for a comprehensive study on the application process.
Okay.
Then there is an additional $171,600 that we would need for system changes for the other provisions of the bill.
Follow up.
Yeah. So why wouldn't that have been in the original fiscal note?
It was included in the fiscal note. The reason we're addressing this now is we expected the Senate to table the bill because it had a fiscal impact and needed appropriation, and then address it in their adoption of HB 2. And for some reason they didn't do that, and so it's here.
Also, Representative Mazur also?
I might come back.
Okay, Representative Weber.
Okay, so having watched the budget process from as far away from it as I can get, am I not correct, though, that although the Senate often passes something and then tables it and just adds it into the budget, there's no reason why, having passed this, they can't add this into the budget as well? There's no prohibition on that, is there? If you know.
Not to my knowledge, no.
I believe that's correct. There is no prohibition on doing that.
All right. So a follow-up. So if that were the case, the reconciliation, if we were to pass this, would simply happen in the course of dealing with the budget process rather than anything else.
Which then we would certainly bring to the Senate through that particular process, yes, if it's not going to be amended here in the bill.
But, by the way, the chairman of Senate Finance is sitting right over there. Representative Weber.
And will you be talking with the chairman of Senate Finance and other members of the Finance Committee about this particular issue as things go forward, even as you're pursuing the policy in the House?
Yes, Representative Weber, we would be glad to do that.
Thank you.
Other questions? Representative Kesselring.
Thank you, Mr. Chair. Thank you for taking my question. So you talked about fiscal note. I'm seeing here online, I'm just looking through based on when it says on or before, starting in line 25, it says on or before May 1st, 2028, the department shall have a detailed report. I see here a lot of things about funding levels necessary to sustain the program to move forward. So if we don't have a fiscal note, I know you talked about all those other details, but the specifics are, do we even know what the program is going to cost to get started, let's say?
Are you referring to the pilot for presumptive eligibility?
Yes, correct.
So there are details in the bill about rulemaking that we would create what the criteria is for that, and simultaneously making the system changes necessary for that. The system changes, the cost for that is an estimate at this time.
Okay.
Anyone else? Representative Lamontagne.
Thank you, Mr. Chair, and thank you for taking my question. I don't know that much about the scholarship program, so I just have a couple general questions.
Sure.
Does a parent need to already have a childcare program ready and lined up in order to get the scholarship? And do you have a waiting list for participation, and how big is that list?
No, they're not required to have childcare already lined up in advance. We do have a number of families who are actually eligible now who have not acquired childcare yet. They have 30 days in which to do that after they've been determined eligible. And then the answer to your second question is no, we do not have a wait list at this time.
Okay. Thank you.
Anyone else? Seeing no one. Thank you.
Thank you.
Also signed up to speak is Representative Paige Boschman from Nashua.
Yes, of course.
Thank you, Mr. Chair, and thank you to the committee. It's nice to see you all here again. My name is Paige Boschman, and I represent Nashua's Ward 4. I am a women's maternal child health nurse and do a lot of community work with the parenting groups in Nashua, and a lot of work with them in the work that I do. But first, I would like to start as a mother of 3 kids who are 12, 10, and 6. And just emphasize that when my 2 younger ones were in childcare, it would cost at least $2,000 a month for childcare. During the summers, when I have to have all 3 of them in camp or something like that, that is over $3,000 a month. So just to give you some context of how much we're talking about here. I do want to say that in the Nashua Family Network, which is that parent-led group that I work with, we talk about this all the time. The specific childcare scholarship program as is right now. It is a huge topic. And what I hear from the folks, because again, mine aren't this small, but what I hear from the folks who have it or have not gotten into it because they've had trouble kind of figuring out the process, is that it's a very complicated process. It's cumbersome. And one of the biggest barriers is they often talk about that need to meet specific hours in order for their hours to be billable. And one of the reasons that that's difficult is because, let's say the kid is out sick for a few days, then that impacts their hours, but it's not really showing their utilization. This is because a child is sick. So that's just one very practical reason that the hours are cumbersome, aside from all the administrative pieces of it. Again, like I said, I talked to lots of parents, and I would say that among my constituents who are generally working class and have younger families, this is probably the number one issue I hear. I hear housing and I hear childcare. And so this, I think, is a really wonderful move towards being able to solve that problem, which we know is a crisis. This issue of childcare is vital to the financial health of New Hampshire families and to the New Hampshire economy. The parents I talk to want to work, but for them, they feel that the system has failed them. So I really think that this bill and these changes that make it just a little bit easier, they're going to give these families the support that they need to do what every hardworking Granite Stater wants, which is to simply work. People just want to go to work, and this is holding them back. So please pass this bill, approve this bill, and let's give them the support that they need. Thank you.
Thank you. Any questions? Representative McLean.
Thank you. Thank you for taking my question. I thought, though, that Ms. Herbert from DHHS said that the federal government required attendance-based. So is this putting us in conflict with the federal law? I'm not. I just want to clarify.
I am not an expert at that piece of it. Do we have somebody that can answer that? Okay, we have an expert who will answer this when they go up. Yes, sorry about that.
Just to clarify that part.
Yeah. Do you want her to answer now, or?
That's up to the chair.
Is that a quick answer?
Yes. Yeah.
Okay.
The federal government requires enrollment-based billing, not attendance-based as it used to.
This would be good.
Yes. Yes, this would be very good.
Anyone else? I think we're all set. Thank you.
Thank you so much.
Also signed up to speak is Stacy Neville, representing New Hampshire YMLAs, and from the very special town of Londonderry, where I happen to live. So,
thank you very much, and thank you for having me today. I am Stacy Neville. I'm the Vice President of Operations with the Granite YMCA. And I'm here representing all of the YMCAs in New Hampshire. Collectively, the 8 YMCAs in New Hampshire are one of the largest youth-serving organizations in the state. We serve thousands of children through our early childhood education programs, before and after school programs, and summer camps. And most of these programs that we have do provide the child care scholarship. These programs provide safe nurturing programs that are critical components to the infrastructure and of working parents and our economy. I'm excited about the proposed changes to the child care scholarship program, specifically eliminating the requirement to track and report hourly attendance, and implementing a system of prospective provider payments, and creating the presumptive eligibility pilot program. These changes would make a significant impact on child care providers and the families we serve. By streamlining the reporting requirements as well as the application and payment system, the state can make this program easier for providers to participate in and parents to access the care that they need to stay in the workforce. We have a few staff members in our organization whose only duties are to implement and daily maintenance of the scholarship program, which does cost our organization a significant amount of money to offer this program. One of the most time-consuming parts of this is maintaining and manually entering all of the attendance hours for all of the children. The waiting period for families to be accepted into the program is also a barrier for families and providers as well. So changing those two things would positively impact so many in this program. We have over 200 kids who utilize the scholarship program, and it's very much needed and is so helpful to families who can enter and remain in the workforce. And I thank you for considering these changes and this program and urge you to vote to pass on SB 243.
Thank you. Any questions? Seeing no questions, thank you. Also signed up to speak is Danielle Robinson from the ARC Learning Center.
Thank you. My name is Danielle Robinson, and I'm here to speak on behalf of the families, children, and childcare providers who depend on the New Hampshire Child Care Scholarship Program. At the ARC, we have 3 locations in Tilton, Hooksett, and Londonderry, and we see firsthand the impact of this program. In our Tilton location alone, over 55% of our families rely on it to afford safe, quality childcare while they work. While this program is essential, it's not without its flaws. Managing it requires a dedicated staff member who spends multiple hours a week just on billing, tracking attendance, obtaining signatures, and monitoring for sudden scholarship link drops. Something that happens without warning over 90% of the time. And because currently you bill after the fact, when the link drops, they're already halfway through. We're already not getting paid for the previous week, but they're a lot of times halfway through the following week. So that's up to 2 to 3 weeks before we notice that they no longer have a link. Because these funds are paid retroactively when the link drops, families suddenly face an average unexpected bill of $900, forcing them to pull their child from care. This leads to job loss, disrupted care, and providers losing tuition they were counting on. A lot of times these families there's no way they can afford that, so they'll leave our center and go to the next center if there's room, which right now there is none. But if there is room, they'll join that center. The same thing will happen. They'll leave that center owing thousands of dollars and they'll move on to the next center. All that does is disrupt the care for the child and obviously leaves all of the providers with a loss of thousands of dollars. Enrollment delays create further hardship. It can take weeks for the scholarship link to appear, meaning that families must either pay out of pocket or delay starting a job. This system is not working for the people it is meant to help. So a lot of times when someone wants to apply, they'll do a tour of our center, then we'll give them the paperwork for the scholarship, they'll fill it out, and then it'll take about 4 weeks before they'll actually be able to start, and that's if they've been able to figure out the process. So I'm a adopted mom, and my daughter was in foster care, so I went through this process myself, and I didn't ever complete it. So I just ended up, because it's my center, she was able to just come with me. But that was, if a childcare owner isn't able to figure out the process for a child that's in foster care, so it should be automatically given, then there's no way that a lot of these parents are able to get through this process. And when they do get through it, then a lot of times the link will drop because they've forgotten to do like a meeting, and a lot of times they're not actually getting these notifications. And then when they call for a scholarship, they're told that, they missed a meeting or they missed submitting a paper, but we didn't even get notification of it as the center to be able to help them and remind them. So neither party is actually getting this information. So it's costing us thousands of dollars. At the same time, we must address the challenges that face our teachers as well. Last year alone, it cost me $270,000 to provide childcare for my teachers' kids. So this is not obviously this bill, but it does affect with scholarship and how much money that it costs the centers. So thank you so much for your time.
Thank you. Any questions? Seeing no questions, thank you.
Thank you.
Also signed up to speak is Alexa Plua from Andy Lex Youth Enrichment Company. I've asked for 5 minutes. If you could keep it closer to 3, I'd appreciate it.
Good afternoon. My name is Alexa Plever, and I am the proud owner of Andy Lex Youth Enrichment Company, a child care consulting and network development company. As a mother, former elementary school educator, family child care provider, executive director, and now a child care consultant and advocate, I fully understand the importance of affordable, accessible, and high-quality child care for not only our children, but our families and our communities. The cost of child care in New Hampshire has increased significantly over recent years, families with 2 children under the age of 5 can expect to spend an average of over $32,000 annually. Due to these high costs, it is estimated that approximately 16,000 New Hampshire adults are not participating in the workforce because of the lack of affordable childcare. The New Hampshire Child Care Scholarship has the potential to address these issues, strengthen the New Hampshire economy, and increase state tax revenue. The scholarship helps qualifying families afford childcare by capping their individual costs at 7% of their annual income. This significant subsidy helps to keep families in the workforce and ensures early learning experiences that supports children's cognitive, social, and emotional development. The primary barriers to accessing the scholarship program, as many of my fellow peers have mentioned, include the complicated application process for families, cumbersome data tracking for providers, and processing delays for eligibility. Consequently, the program is significantly underutilized, leading many families to seek alternative childcare solutions or remain out of the workforce altogether. As a child care consultant, I have worked with organizations like the Community Development Finance Authority, CAP of Stratford County, 2 economic development corporations, United Way, and higher education systems. Together, we have built networks, enhanced the quality of child care services, explored opportunities to create new child care facilities, and recruited early child care educators. However, access to affordable childcare for families remains essential for each of these efforts to reach their full potential. For these reasons, I support SB 243, administrative improvements to the New Hampshire Child Care Scholarship Program for parents and providers, educators, are crucial. The bill aims to streamline paperwork through fast-track applications for families and simplify data entry for providers. It will also reduce the processing delays and improve payment system to childcare programs, aiding in families and businesses, also communities, to succeed.
And please start wrapping up.
Thank you.
Oh, okay, that was great. Perfect timing. Any questions? Seeing no questions, thank you.
Thank you for your time.
Also signed up to speak is, and hopefully I pronounced the name, Cora Hoppy. Is that correct?
Yes.
Oh, wow, okay.
I appreciate you guys and listening to our testimony. My name is Cora Lynn Hoppy. I'm the Executive Director over at Rochester Child Care, and I'm going to speak from 2 points of view, industry and as a provider. As a parent, I struggle, but you guys will hear that a lot. So I just want to come in from 2 angles. As a provider, I have 135 children from 6 months to 5 years. I have 245 children from 5 years to 12 years. I currently utilize the scholarship system at a 60% rate, which is incredible. We're very fortunate. We have so many people linked to that system, but I hate to call Karen out. She was wrong. Our linking form is required in order to start on the child care scholarship system. So they have to find a provider willing to give them that linking so that they're able then to apply for the scholarship system. On top of it, the barriers that happen when you are inputting the data into the system is a nightmare. It can often affect parents and their care. So we are enrollment based, but based on the number of hours a parent works is dependent on their subsidy. So if I have a parent who drops down because their child is sick, or for example, an LNA who she was caring for has passed away, she loses that amount of time in the subsidy, so she has to drop to part-time. I see this constantly. I have children who are on DCYF. We link up very easy with them, but what happens is if they lose track and they're starting to get into a safer system, they will not track that anymore and they have to jump onto the scholarship system themselves. When you are struggling with misuse in housing and childcare, that is the last thing on your mind. So I had to watch a child walk away and not have access to him anymore because his parent no longer has scholarship and now has no housing and no one tracking them. I see this weekly. I work with a lot of other organizations that help with misuse and treatment, so I try to partner with them to offer that care. I rely on the scholarship system to pay my workman's comp, my liability, which is absolutely outrageous right now. It's hard to stay with insurance as a child care provider because it is hard to track when a kid is going to chuck a water bottle at your head. And you can't have procedures and policies that insurance people like in order to prevent that from happening, unless you just don't take those children, which I can't. I have to take those children. They need us the most. So we try to balance that out. Now, as an industry, I went through market failure, and it continues to be in market failure. The market cannot pay for the cost of childcare. That's why we're still struggling. On top of it, I took a $600,000 hit. So I have to eliminate almost all risk as a business owner in order to continue running in Rochester. We help our fire department. We help our police officers. Without our service, our city would no longer run. And just a quick elephant in the room, and then I'll be right out. Head Start. I want to be quite frank with you. The Boston Regional Center was shut down, and right now it's only contracted workers working out of there. We're waiting for grant funding to come down. Washington State is going through the same issue where their Seattle regional office was also shut down. Today was an article stating that 400 children just lost slots because they are not getting funded through Head Start anymore. We will see this in our state. Head Start currently has 1,400 slots. What are we going to do? In order to help save this business, we need all of this to go through so we can have providers take on scholarship, because it's going to be a nightmare. I appreciate you guys. Thank you.
Thank you. Representative Palazzo.
Thank you, Mr. Chair, and thank you for your testimony and taking my question. I don't know your business well. Could you explain 60% number, 60% rate? Does it mean that 60% of your students fully rely on this scholarship now?
Yes, families and staff.
Thank you.
Anyone else?
Yep.
No, Representative Kesselring.
Thank you, Mr. Chair. Thank you for taking my question. So how, in your perspective, would this bill affect and help your business?
It would allow me to trend easier. So when those big bills that show up, like the insurance bills when you pay in installments, if I get that money up front first, I'm not worried about chasing it later. And if I have that presumptive eligibility, I'm not worried if people get unlinked, because then I know that money's still going to come in and we can work with the paperwork in order to still have that. But if I at this point, wait until at the end of the month, potentially I lose 10% if people are getting unlinked. So this would help maintain my budget better and make it easier for me to trend so I can afford to provide my workforce money.
Follow-up?
Which is a payroll of $100,000 every 2 weeks with 84 employees, not getting paid a livable wage.
Just wanted to make one follow-up question to that. So based on what you just said, is there anything else you see that we could be missing that would be that could affect you on this?
I'm not sure, to be honest, but I can look and I can email you.
Anyone else? Seeing no one else, thank you. Also signed up to speak is Megan Brabeck from Save the Children Action Network. Hopefully I pronounced the last name correctly. I'm getting really good at this.
Good afternoon. Copies of my testimony, as well as a one-pager about a recent poll we did in New Hampshire, are coming around. On behalf of Save the Children Action Network, I'm here to express our strong support for this legislation. This bill is a critical step toward making childcare more accessible and affordable for families across our state by making it easier for childcare providers to accept the scholarship, and it aligns overwhelmingly with the will of Granite Staters. As you all know, childcare in this state is unaffordable for most working families. The average cost for a family with 2 children under 5 is $32,000 a year, or about $2,700 a month, more than what most residents pay for housing or health care. I am a mom of a toddler myself, and I can attest to this. I have grandparents who help me with childcare, and I still pay about $1,500 a month for part-time daycare. Parents with reliable, quality care miss fewer work days, they're more productive, and they're better able to provide for their families. According to a recent study, the New Hampshire economy loses an estimated $500 million each year from lack of childcare for infants and toddlers. And now to the poll, which you have one-pagers on in front of you. In December of last year, SCAN conducted a poll in our state asking voters their thoughts on childcare. A few important takeaways. Our voters view the cost of childcare as a serious issue on par with the cost of groceries. Nearly 3 in 4 say that the state should do more to help working families through improving their ability to find quality and affordable childcare in preschool. And nearly 9 in 10 voters are supportive of adequate funding for the childcare scholarship program, with overwhelming support across party lines because they see the need to make childcare more accessible to families with low and moderate incomes so that parents and caregivers can work, attend school, or look for a job. So there's clear public support, which underscores the urgency of reforming our childcare system. This bill directly responds to the concerns of providers by streamlining the process. And by making these changes, the bill will provide families with the stability that they need to work and support their children, while also enabling providers to spend more time on what matters most, which is caring for our kids. So we urge you to support this bill. I will take questions if you have any.
Thank you. Any questions? Seeing none. Thank you.
Thank you very much.
Also signed up to speak is Trina Engelfinger from New Futures.
I have some written testimony from myself, and I'm also passing around some from Errol Warden, who had to leave. I apologize. Thank you all so much. My name is Trina Engelfinger. I am the Early Care and Education Policy Coordinator at New Futures, a nonpartisan nonprofit organization working to improve health and well-being of Granite Staters. And I'm here today to speak in support of SB 243 because it will improve working families' access to childcare. The Child Care Scholarship is a funding program for employment-related childcare. It's administered by DHHS, and the federal government more than doubles the state's investments in the program. I wanted to address the point about the fiscal note and the ongoing costs of the program. According to the fiscal note, this is really just a one-time expense to get all of these changes up and running. There are no ongoing programmatic costs associated with this bill. I also want to just note that the scholarship is a parent choice program. Parents alone choose when and where their child will receive services in this program. And the options range from in-home care to faith-based care to small and large childcare centers, and you'll hear from all of those folks today. This fall, New Futures engaged in interviews and listening sessions about the Child Care Scholarship Program with stakeholders, and we heard resoundingly that both families and providers were facing barriers when seeking to participate in the program. And that included documentation requests for families and data entry requirements for providers that went far beyond what's actually necessary for the program. And SB 243, as Mr. Taylor discussed in his introduction to the bill, would remove those barriers for families and providers. I'll just conclude by noting that Governor Ayotte has expressed support for cutting red tape in the Child Care Scholarship Program. And SB 243 provides an opportunity to do that in a low-cost and very practical way. This bill received unanimous support in the Senate, and I hope that the House will support it as well. And I'm happy to take questions.
Thank you. Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. I'm relatively new to this program and budget process behind it. I'm a little bit confused. So we heard testimony that after it will be implemented, there will be more kids staying on scholarship and more money going to child care providers. So if it's just one-time expense, where those money are coming from? Is it some additional budget appropriation in different bills, or where the money will be coming from?
Thank you so much. That's a great question. Again, the program is funded through a state and federal partnership. The funding is for the broader program is included in the bill. The extension via presumptive eligibility, again, under the fiscal note, was not thought to add any additional expense because it simply expands by at most 60 days the time that an otherwise eligible family is likely to receive the program. And the program itself is eligible for a TANF transfer. So if at any point the access to the program exceeds the available budget, that is one option. But also our rules in New Hampshire create a wait list if we run out of funds for the program. So the program will just simply put new applicants on a wait list if there isn't funds available to serve them.
Any other questions? Representative Kesselring.
Thank you, Mr. Chair. Thank you for taking my question. So has the program ever run out of money in your experience?
I believe there have been wait lists in the past, but that is not the case currently.
When I was in the department, there were wait lists.
Yes.
Yeah, that was 6 years ago, but
Thank you.
anyone else? Seeing no one else? Thank you.
Thank you.
No one else has signed up to speak on SB 243 FN. Does anyone else wish to speak? Seeing no one, I'm going to close the public hearing on SB 243 FN and open the public hearing on SB 119 FN and recognize the prime sponsor, who is a member of our committee, Representative Yuri Polazov. And Representative Polazov, we need a pink card after you get done, please. Thank you.
So it's each set, right? I did 14 here, maybe some people can share.
Okay. So one of each stack?
Yeah, one of each staff, yeah.
Oh, okay.
Thank you, Mr. Chair. If you don't mind, I will let Representative Potenza.
I mean, Representative Potenza wishes to join you, that's fine.
Is that your stuff? Oh, okay. That's it for.
This is,
Just one of each?
it's a set,
Okay.
it's a set. Hey, you can,
Yeah, thank you. Thank you, Mr. Chair. Just for the record, Representative Kelly Potenza, Stratford District 19. So I'm just going to say good afternoon, and Mr. Chair, and thank you, members of the committee. I really like the opportunity to be able to speak today on an issue that's very important to me and a lot of constituents. And it really lies at the intersection of public health, personal freedom, and frankly, common sense, which is making ivermectin available over the counter. For decades, ivermectin has been a well-known, well-studied antiparasitic medication. It earned its discoverers the Nobel Peace the Nobel Prize in Physiology and Medicine in 2015, which that's the first document that I gave all of you. And that was due to, of course, its global impact in treating diseases like river blindness, lymphatic, filariasis. And in fact, the World Health Organization, of course, listed ivermectin as an essential medicine. And the U.S. Centers for Disease Control and Prevention includes it in its treatment guidelines for strong gliodiasis and other parasitic diseases. So ivermectin has actually been administered over 4 billion times around the world and has an excellent safety profile. Yet, here in New Hampshire, after passing this bill in 2022, only to be met by a veto from the governor at the time, access to ivermectin remains unnecessarily restricted. Despite its long history of safe usage, patients must navigate prescription requirements and bureaucracy just to access a drug like, in most all cases, carries a much lower risk than over-the-counter pain relievers like Tylenol. So the question is simple: why? Why should a drug with decades-long track record of safety and effectiveness not be available without a prescription, especially when many far riskier substances are? Making ivermectin available over the counter would empower individuals to manage their own health more efficiently. It would also reduce the burden on healthcare providers, freeing up resources for more complex medical issues. For anyone dealing with parasitic infections and autoimmune issues, the ability to walk into a pharmacy and purchase proven, affordable medication should be a basic convenience, not a legal obstacle. Some might argue that misuse is a risk. Well, that's actually true of any medication. But restricting access due to hypothetical misuse is a poor substitute for education and responsible guidance. By providing clear usage instructions and public health information, we can equip people to use ivermectin safely, just as we do with antihistamines, antacids, and actually even insulin in some countries. We trust individuals every day with the responsibility of managing their own well-being. It's time we do the same with ivermectin. Let's bring policy in line with science, history, and common sense. I urge this committee to look at the hard evidence and then to take the right step forward. Let's give people the access they deserve, and let's make ivermectin available over the counter. So I just wanted to give just a couple, facts that are kind of really important at this. So I know ivermectin really became on everybody's radar during COVID, and I do have COVID documents that are in there, but I didn't want this to be focused on that, only because, I was very familiar with ivermectin because I have a very good friend that suffers from tick-borne diseases and has for the last about 20 years. She's been taking ivermectin daily for that amount of time. Her entire family never had experienced anything that had to do with COVID or any of that, and it was just kind of a nice added benefit that was giving her an extra layer of protection even during that time when she already has autoimmune issues. We already have in the United States 2 states right now that allow ivermectin to be sold over the counter, and there's a whole slew of other legislation that's going through right now. So we've got Idaho that that legislation passed both chambers. Idaho's actually that's right now. The 2 that are legal are Tennessee and Arkansas. Tennessee has been legal for 3 years. Arkansas just passed. Idaho just passed both chambers, and the bill is on the governor's desk, waiting for Brad Little's signature. So Louisiana, West Virginia, Kansas, South Carolina, and Pennsylvania is very close at this point too. But I just would love to talk about all of the other countries that have ivermectin over the counter and have had that for a long time. Mexico's a great example, but when COVID hit in 2020, 8 Latin American countries immediately rushed to distribute mass quantities of what they called COVID kits. And it had a whole bunch of stuff in it. But of course, one of the biggest things that was in there was ivermectin. And so it was like Brazil, Honduras, Panama, Peru, Bolivia, El Salvador, Guatemala. And then, so that was all happening. Australia, for example, so in the 1st of June in 2023, this is pretty important as well, they were very, very strict on COVID protocol. So they actually, prescribing of oral ivermectin for off-label uses will no longer be limited to specialists such as dermatologists, gastroenterologists, and infectious disease specialists. So that they made a final decision to be able to open that up as well in Australia. A very well-known, his name is Dr. Miller. He's American Board of Emergency Medicine. He's actually an inventor of this it's called the EZIO. It's a medical device used for intraosseosis. It basically delivers medications and fluids directly into bone marrow. He was an author. He was the chairman for 5 Baptist ERs for over 10 years. He treated over 130,000 ER patients. He got ranked Humanitarian of the Year in 2017. WSJ Award, Invention of the Year in 2008 and 2012. So he actually is currently on a missionary in El Salvador working with a whole slew of different medical patients. So this is his quote: "I used ivermectin to successfully treat over 1,000 COVID patients without losing one. I was banned from all social media for spreading information. I lost many friends and credibility, but the president of El Salvador praised me. And now we've come full circle, and all of these things have come to light." There was a lot of things that were just misinformation, of course, during COVID, but let's just talk about the safety protocol alone for ivermectin, okay? It was approved for human use in 1987. Like I said, it's been administered over 4 billion times around the world. It's on the list of the WHO's essential medications, won that Nobel Prize. The most important thing is it's not considered toxic at all to liver and kidneys and lungs, which, ibuprofen, Tylenol is. It's got no adverse effects in using ivermectin to treat COVID and other things. They're now looking at it, of course, for other autoimmune diseases, rosacea, and cancer. We've got so many studies. There is a document that I gave you, which is, so here's just some great stats for COVID. But this second page is actually the beginning document for a 174-page document that shows you all of the studies that have been done and gives you kind of a briefing of it. I wasn't going to print that out for the committee, but I will be happy to follow up and give you these things in nice little links or attachments to your email afterwards, because I just think it's important to have that. One of the biggest things is it doesn't cross the blood-brain barrier. And there are over-the-counter medications right now that do, and that's very dangerous. It gets metabolized by the liver. So I can go on and on about all of these wonderful things that when it comes to ivermectin, and
we appreciate all the information you've given us.
Yeah, and I will end with the other, the documents that are here. This one is basically ivermectin, a multifaceted drug with a potential beyond antiparasitic therapy. That's very important to read. The abstract, that paragraph is fantastic. It talks about its anti-inflammatory, antiviral, anti-cancer properties. I told you about the Nobel Peace Prize. And this one is really the starting of ivermectin. So it was because the drug was discovered in the late 1970s. It was actually called avermectin before it was ivermectin. And the beautiful part about this is it talks about how it was used. And the topic of it is ivermectin, wonder drug from Japan, the human use perspective. This is a fantastic article if you have the time and you're interested in reading it. But I'll open it up for questions. That's it.
Thank you, Representative McLean.
Thank you, Mr. Chair. Thank you for taking my question. So let's take COVID out of it. Let's just go back to 2015 in a time machine. So many drugs that are safe are over the counter, but many drugs that are safe are also you need a prescription for. So, and with your friend who had a tick-borne illness, she used it for a very long period of time. Do you know why it was in 2015, pre-COVID, all this stuff, that Tylenol was deemed safe to be over the counter, but ivermectin at that time was deemed to not be safe for over the counter and had to have a prescription?
It was never over the counter from what I know in the United States. So I don't have any background of that. I do know that she was it was very easy for her to get ivermectin and for pretty much anyone to get ivermectin at that point. So that was 2015. Moving forward, this really all started in 2020 when there were studies that had been done previously showing that it would stop like the viral replication if you're taking it early, the cytokine storm, those types of things. But it was never over the counter here in. It's cheap. It can be produced. There's a lot of pharmaceutical companies want kind of control of that too. But if you look at all of these other countries, it's, when my mom went to Mexico 3 years ago, she's like, oh, they sell right there at the kind of like at the market. So it's just a very common thing versus, of course, here. So.
Other questions? Representative McGrath.
Thank you, Mr. Chair. Thanks for taking my question. I just want to say in like 40 years of pharmacy, I probably dispensed ivermectin less than 10 times. It's just wasn't something that was used widely. I do want to add to your testimony though, in 2020, when the government and the news media were saying how dangerous it was, the two biggest medical journals in the world, the Lancet and the New England Journal of Medicine, published articles about how dangerous it was, which they had since retracted. And
Remember, you're supposed to be asking a question.
Thank you. And they had since retracted it and said they were under pressure for publishing it. So I guess my question is, why would they do that?
There's a lot of different reasons. Mainly it's money, it's power, it's control. I think everyone on this committee, it doesn't matter where you fall. This isn't a partisan issue. We know that drug companies have a crazy amount of influence. The amount of safety that was done. I mean, they spread they gave this out freely, all these other countries, in a kit to say, hey, we're going to help you out during COVID. It was crazy. They already knew the safety protocol. So for that propaganda and frankly, those lies to happen, it's a lot of it has to do with big pharma and controlling all of that. I was very, very upset for a long time. The reason why I ran for, to be a state rep was because of the stuff that took place during COVID and a couple other reasons, and I was really upset about it. So this ivermectin, I started researching, right in 2020, and I was just blown away. Like you had the CDC that basically put out an image that said, of a horse, and it was just incredible when people had been taking ivermectin for multi-use different things for decades. And, it's really hard. And there was a lot of that stuff that was going on. So I'm really glad where we are. It's 2025 and all of that misinformation is behind us. I love that I have a document that shows, that it was called a wonder drug all the way back into the 1970s. So, I'm hoping that New Hampshire can do this just along with all the other states and all the other countries.
Would you believe that I knew of several people during COVID that were heading down a very dangerous path towards hospitalization that stopped the minute they started taking ivermectin?
Yes, I would believe that, and I'm very familiar with it. So, I'm going to give a personal story. So, our family, except for my husband, we got COVID, and this was early on. It wasn't bad. I had no taste, no smell, so that was kind of the thing. I had called at the time, this was before everything got shut off, frontline doctors, and I talked to a doctor on the phone, so it was like telemedicine, and I received prescriptions for ivermectin and hydroxychloroquine. And then my husband went on hydroxychloroquine prophylactically, and he never got sick. And he stayed on that for a while. It's just kind of a force field around him. And I was better within 3 days. And it was, but the doctor from Arizona was very clear. She said, if you can get your hands on this and stock up for your family, make sure you do. Because it's going to come down and they're going to stop all of this because it's just the nature of the beast. And in New Hampshire, I know that this isn't, hydroxychloroquine was through basically an executive order, the governor along with DHHS, they stopped that here in New Hampshire. And that is the reason why, if you look at other countries that take hydroxychloroquine is, kind of like you're taking aspirin, they didn't have any outbreaks of COVID. So we know better, we do better. This is amazing for people here in the state. This is enabling legislation, and I'm hoping that we can make it happen again. We already passed it once, 2022, so let's do it again.
Any other questions? Representative Markell.
Thank you, Mr. Chairman. Thank you for taking my question. Perhaps I overlooked it. Are there any surrounding states in New England that are taking the same course of action that you have, or is ivermectin available in any of in New England area?
Not in New England area. I had mentioned the ones that I was talking about that are working on, Northeast, right? If you consider Pennsylvania, they're getting very close to passing the legislation to make ivermectin over the counter. I should probably mention that this is on the radar of the federal government right now, so that's a good thing. But you know what? We're not going to worry about them. The state's got to do their own thing first. I think it could happen on the federal side. That would be great. That makes it a lot easier for everyone else. But that's the closest one I would say.
Okay,
Thank you.
Quick follow-up. Thank you. Are you aware of any pending legislation in New England that would duplicate what you'd like to do?
No, I'm not. I did talk to a state rep in Ohio, and they, we're all on different schedules, and so that's going to be coming there. They just passed another piece of health freedom legislation, so we're going to see a lot more of this, especially since Arkansas just passed theirs, which is great.
Okay, thank you.
Okay, Representative DeLamus.
Thank you, Mr. Chairman, and thank you for taking my question. Would you believe I've been administering ivermectin to horses since was 1981, and that ivermectin has been found to be safe across a spectrum of different animal species: cats, dogs, horses, humans. It's a universal drug and can be used safely across all of those parameters. So I'm very glad that you would take my question, and thank you for coming.
Yes, I'm very familiar with that. It's used in a wide spectrum in mammals, and it was amazing. So when it was first used in animals, they saw how from testing, of course, with animal testing and all, they saw how safe it was. And then they're like, wow, this could be used for this, this, and this. And of course, some majorly debilitating diseases that are overseas. And that's when it started. And that's why, they've called it, that's why it won the Nobel Prize. That's why, but that was in 2015, I believe it won that. But we're talking about other countries that have been kind of yelling about this off the rooftops for a long time, so.
Anyone else? Okay, thank you.
Just to clarify, the last piece of paper is Amendment 1606 that will be introduced during executive session, just changing 2 words in the first paragraph. And Idaho actually just signed the bill into law yesterday, so now it's 3 states.
Okay,
3 states so far?
3 states.
Do you have more copies of that amendment?
Yeah,
I
thought it was the old one.
I thought it was 1498.
Mine, I've got the one that's
He's bringing more.
Okay.
Yeah, and if you would like, I can give you, it's a long list of countries, dozens of countries that are over the counter, if you'd like that as well, so.
Thank you, Representative Potenza.
So this is the new one. Okay, I got it now. Thank you.
Okay, thank you, Representative Palazov. We need a pink card from you also. We do have one from Representative Potenza. Also signed up to speak is Jonathan Ballard, the Chief Health Officer for the Department of Health and Human Services.
Up to the chair. Okay.
What's that? Well, I had already promised Chief Ballard. I think he's under a...
I'm sitting here.
Okay, you're next, Senator.
Okay.
Actually got 2. Mr. Williams had already filled out one for you, so we have 2 from you.
Well, thank you, sir. Certainly we give deference to Senator Gray to go
And
before me.
you said under
was a-
5 minutes, but if you can make it 3, that'd be great.
Absolutely, very short, sir. For the record, my name is Jonathan Ballard. I work as the Chief Medical Officer at the New Hampshire Department of Health and Human Services. I'm a family physician by training. The department does not take in a position on this bill and providing information only. So I wanted to remind the committee that this underlying bill has a savings to the state and was included in the governor's budget of at least $9 million. The second half of the bill deals with its own standing order for lab tests and over-the-counter medications could potentially provide much more savings beyond the $9 million that this underlying bill provides. Remind you again what a legend drug and a non-legend drug is. A legend drug is only those drugs that are prescribed with that need a prescription. And there was a question earlier that Representative McLean had about why this drug is a prescription drug versus a non-legend drug, which is an over-the-counter medication. So that's determined by the FDA, and they determine that based on really 2 factors. One is the safety profile performed in studies, and then also the length of time and the post-marketing surveillance that is done on a medication. So the FDA makes that determination. Typically, it's not individual states that do that. For this bill, I just want to point out a few things in the language of it that you may want to pay particular attention to. I've seen this language presented in some other states and some areas that doesn't seem to be aligning potentially with New Hampshire. One aspect of it, it does not mention that anything about physician assistants. In New Hampshire, when physician assistants, this is legislation that you passed last year, reach a certain number of hours of education and patient encounters, that they have independent licensure. So that's not included in this language. So the reason why the drug is a prescription drug is that it's not been considered safe in pregnancy. So the effects on the unborn baby or the fetus has not been determined safe. It does pass through the breast milk, and it is not FDA indicated for any child less than 15 kilograms, which is 33 pounds. It does interact with liver and kidney diseases, and this is the reasons why the FDA makes it a prescription rather than over the counter. In New Hampshire, we have two cases where drugs are prescribed through a standing order. Both of those two cases are in emergency situations, one being naloxone or Narcan, and the other one is an EpiPen. So both of those are kind of emergency situations where it's life or death situation. This would be the first time in New Hampshire that it would not be a life or death situation, that a standing order for a prescription is actually effective in the state. If I may indulge, I have a few more just points.
A few seconds.
A few seconds, sure. Dosage is very important in prescribing this medication. The screening protocol doesn't mention anything about pregnancy tests, and also this bill doesn't say anything about the cost. It does mention that the individual can be charged. It's not allowable for Medicaid. You cannot charge any Medicaid client, so I would ask for that to be changed if it were to go through. And it doesn't talk about cost for does Medicaid or insurers, are they required to pay for this medication? Are they also required to pay for the pregnancy test? And it doesn't mention anything about liability protections to the pharmacist should they be issuing this medication to an individual that doesn't fit the safety profile for the medication. So with that, I'll stop and take any questions. Lastly, it doesn't mention whether it's oral medication or topical medication. Topical medication is used for head lice and lotions, topical creams. It's much safer profile versus the oral profile, which does have typically a diagnosis involved, where you proactively determine that the patient is the right person for that medication. I will stop.
Thank you, Representative Weber.
Thank you. Just for clarification, when you started, you spoke about a $9 million savings to the bill. That was the underlying bill, not this amendment. Is that correct?
That is correct. This amendment would cost money to the state with additional costs,
Are there any estimates as to how much additional money?
I think it's indeterminate.
Okay, thank you.
Representative Kofal.
Thank you, Mr. Chairman. Thank you for taking my question. So, regarding your statement about standing orders applying to Narcan and
EpiPens.
So, are you aware of RSA 31847L, I believe?
I'm not.
Which authorizes the dispensing of hormonal contraceptives via standing order. So would that square with your statement, or would that be?
It does, because substantive that has actually gone over the counter federally. So that's sort of a moot point at this point.
Thank you.
Representative McLean.
So just to kind of get these comments back to the reason that it is classified when they did the studies as not over the counter but need a prescription is because it's not safe for pregnancy, pass through the breast milk, negative impacts. So if you have kidney disease and the dosage. So, I mean, if I look at my bottle of Tylenol, it says, okay, adults, this is your dosage. Children, this is your dosage. So that cannot be done with ivermectin, or it's much more complicated based on the use. Try to explain that.
No, that's a very good question, respectable. I think it's because you have to proactively determine that the patient is the right one to receive it versus, I don't know, I cannot fully answer your question, and I respect the question, but I think it's mainly because you have to take a proactive decision that this medication is needed for this patient versus an over-the-counter medication that's used for wide-ranging general conditions.
Anyone else? Representative Kesselring.
Thank you, Mr. Chair. Thank you for taking my question. So I listened to your testimony briefly there about how ivermectin specifically doesn't say in the bill about prescriptions or whatever it is for prescribing it, so Medicaid pays for it. So I'm guessing that Medicaid currently pays for ivermectin. That would be my first question.
Yes, we actually have 0 prior authorizations. So any provider who prescribes ivermectin for any condition, Medicaid will pay for it. It's such a rarely used medication. It's not something that's a high cost to the state as far as the Medicaid program for prescribed medications. And it can be prescribed for COVID, for anything, and the state Medicaid program will pay for it.
Okay, a follow-up. So I guess my follow-up question would be, if this were to pass, would I mean, drugs like Tylenol, I'm guessing aren't covered under Medicaid because they'd be over the counter. So that would change that. Oh, was there any provision under current law that would still allow this drug to be prescribed, let's say, even if it was over the counter in Medicaid to cover it?
I think that raises an interesting question I have not considered.
Okay.
Okay, I'm seeing no other questions. Thank you. And now Senator Gray, please come forward. Thank you for your patience. I had received a text earlier in the afternoon asking.
Pay me so much money, I got it. Hello, my name is James Gray. I represent Senate District 6, which starts up in Alton and Gilmanton, comes down Route 11 to Rochester and Stratford. I'm not here for or against ivermectin. Okay, I went to the doctor's Monday, and on my way out, I says, "Hey, tell me about ivermectin." She started giving me stuff where she doesn't support it. I says, "Yes, but does it hurt anybody?" And she says, "In most cases, no," which is consistent with the testimony that you've had so far. It's that there could be cases where it is contraindicated. But that's not why I'm here. I talked to a pharmacist. I says, well, what about this? And the pharmacist says, well, the way that this bill is written, there are problems. Okay? Fine. Whatever. What I'm here is in support of the base bill. Okay? The estimate that I have is the original bill is the $9 million plus the other things that he talked about, and I've been given an estimate of $12 million. And as the chair of finance, I need the $12 million. Anything you put on this bill that might not get it passed takes away money that I can use for all of those things that you had to cut out of the budget to get a balanced budget. So, again, ivermectin, okay. No ivermectin, okay. I need 12 million. When I came here the first time, I told you, I usually go by the Hannaford brand, right? But when the brand, I've got a coupon and the name brand is cheaper, I go buy the name brand and use my coupon. That's what the underlying bill does. And it'll save the state approximately $12 million. And I need that $12 million.
Mr. Chair. Okay. Representative Weber.
So am I right in thinking that what you're saying is that it would be wise for those people who support this initiative to file it as a standalone bill next term rather than attaching it to your $9 to $12 million?
I wouldn't go as far as you did, Representative. What I would say is that anything that puts the underlying bill in jeopardy, I'm not in favor of going on the bill.
Anyone else? Seeing no one. Thank you, Senator. Also signed up to speak is former Representative Jerry Knirk.
So for the record, former Representative Jerry Knirk, MD, and this amendment's the same as HB 1022 from 2022, when people wanted to use ivermectin for the treatment of COVID. A lot of things are said about positive studies, but you have to look beyond the abstract when you look at studies. There are a lot of quote-unquote positive studies that were really poorly done. When you dig in and you really look at the study, they're not good, and anecdotes are not data. High-quality clinical studies have not demonstrated efficacy of ivermectin in treating COVID-19. A troubling issue is that recently online influencers have been touting the use of ivermectin to treat cancer and a number of other medical problems. There is ongoing research into ivermectin in treating cancer, but there's no evidence yet that it cures cancer in humans. This is not an issue of censorship. It's simply subjecting these studies to the same robust analysis that we have to give to any other study. Ivermectin does have some side effects. It is fairly safe, but it can interact with other medications, especially blood thinners. In large doses, it can be toxic. The biggest risk is that of patients using ivermectin and foregoing proven therapies. That can lead to progression of their underlying disease, and that's particularly a problem in cancer, which may be curable early, but incurable late if you've been treating it with ivermectin instead of getting the appropriate care. So again, it's not to say that ivermectin is not a good drug. It's a great drug. It's excellent in the treatment of parasitic worms, but its efficacy in COVID, cancer, and a host of other maladies is simply not proven. Permitting a pharmacist to dispense a medication by standing order requires a well-evaluated protocol established through a broad consensus of providers and pharmacists using the best available evidence, not anecdotes. A broad consensus supporting the use of ivermectin in COVID-19 or cancer or anything other than parasites does not exist. Governor Sununu's veto message on 10/22 stated, quote, "The state currently has only 4 instances in which pharmacists can dispense medication without a prescription. These medications are smoking cessation, contraception, substance use disorder, and treatment for sexual assault, all of which have gone through rigorous reviews and vetting to ensure they meet all the necessary protocols prior to a medication being dispensed via standing order. All drugs and medications should be subject to the same rigorous process if they are to be dispensed by standing order," end quote. And as he pointed out, ivermectin can be prescribed off-label by a provider. Off-label prescribing is common. The FDA states, quote, "Healthcare professionals may choose to prescribe an approved human drug for an unapproved use when they judge that the unapproved use is medically appropriate for the individual patient," end quote. You can do it. Providers are free to prescribe off-label. I did that. But they do need to follow the best evidence in doing so, and they have to have a patient-provider relationship. Standing orders of pharmacists should not be used to dispense medications or indications that are not clearly supported by the best available medical evidence. Ivermectin, does not reach this level of evidence for anything other than parasites, and providers already routinely prescribe it for that indication. It's easy to access for the appropriate use. Online influencers' recommendations do not represent best available evidence. So please vote no on this amendment and let the underlying bill, which is important, get passed. And I'd be glad to take any questions.
Thank you. Any questions? Seeing none. Thank you.
All right, thank you.
Also signed up to speak is Caitlin Como from the New Hampshire Pharmacists.
Good afternoon, Chairman McDonald and members of the committee. My name is Caitlin Como. I am a practicing pharmacist in the state of New Hampshire. I've been a lifelong resident and practicing for 10 years. I'm also here representing New Hampshire Pharmacists Association in opposition of this amendment. For those who are not familiar, one of the core functions of a pharmacist is to ensure that patients receive safe and appropriate prescription medications. I consider us to be sort of a quality assurance department of the medication use process. So we assess prescriptions for the correct dose, route, frequency, clear instructions for the patient, relevant drug-drug interactions, and side effects. We also provide patient counseling on how to safely administer the medication. But unfortunately, pharmacists do not always have access to a patient's full medical history, which is critical to ensuring safe medication use. And we rely on providers, prescribers, doctors, nurse practitioners to send appropriate prescriptions knowing the patient's full medical history. As some of the others have testified, there are currently only 4 situations in current statute that allow for a standing order to be used in the place of a prescription. And this is the exception, not the rule, to medication use. While standing orders can be an effective means of increasing access to medications, the benefit is really dependent on therapy-specific training by the dispensing pharmacists. We're not prescribers by our own training, so in order for an effective standing order to be in place, we need proper training. The proposed amendment to this bill does not establish such a training requirement, which is outlined in some of the other standing orders in our state. It also does not establish rulemaking authority for the Board of Pharmacy that would help ensure that adequate training is in place for pharmacists. I wanted to highlight a concern in regards to how this may affect frontline pharmacists. I anticipate that this could cause some potential conflict and tension between a pharmacist and a patient if an individual pharmacist chooses not to dispense the medication or not to implement the standing order. In my experience, community pharmacists are chronically overworked and understaffed. Ivermectin use has become a controversial topic, and a standing order such as this would have the potential to add significant burden to an already stressful workplace. So I'm advocating on behalf of the pharmacists in New Hampshire against this amendment. I truly believe that patients and pharmacists would both be best served by obtaining access to ivermectin through the safe and lawful channels that we currently have. I have nothing to say against the medication's efficacy. I think you've heard that it does have its role in therapy, but the smartest option is to have a patient and provider conversation about the use of that medication first prior to obtaining that medication. And I'd be happy to take any questions. Thank you.
Perfect timing. Representative McGrath, who is a pharmacist.
Yes.
Hi, how are you? Thanks for taking my question. Thank you, Mr. Chair. So this bill has two parts. We're looking at the amendment. The second part of the bill, which I have a problem with because of some of the things that you've said, is that the chief medical officer can put in standing orders for over-the-counter medicines, medical supplies, and laboratory tests. And how would that affect the pharmacy business?
I just want to clarify for the committee the difference between a standing order and an over-the-counter medication, just for some clarity. A standing order, as you allude to, requires that there's a provider that signs a piece of paper with a clear protocol for a pharmacist to dispense something, either a supply or a medication. An over-the-counter medication by itself is not regulated the same as a legend drug, as Dr. Ballard mentioned. But I don't know in terms of the other pieces of the original bill. I'm not sure exactly how that will impact pharmacy. From my experience, the volume of prescriptions that we dispense based on a standing order is very low. I anticipate that with this amendment in relation to ivermectin, we would see potentially a significant increase in people seeking access to that. But again, I stand by my original statements. I think the best course of action is to have a conversation with your doctor about appropriate use of this antibiotic. Thank you. Did I answer your question?
Sure. So the second part of the bill, the standing orders would be so that Medicaid patients can just come in and get over-the-counter meds on a standing order, so the volume would be very high.
Okay.
So again, how would that affect the retail pharmacy business?
That would certainly cause an increase in workload for pharmacists. Patients can grab over-the-counter medications off the shelf and don't need consultation with a pharmacist, but the process that happens if they're seeking a medication via standing order to be paid by Medicaid would be that they come to the counter at the pharmacy, they ask the pharmacist to enter an order on their behalf, which takes time. The pharmacist has to process that, cross-reference their medical record, their drug list, count the medication, label the medication, provide counseling. So yeah, it certainly would add some burden and time to pharmacists and their workload.
Representative DeLamus and then Representative Weber.
Thank you, Mr. Chairman. So first of all, you said that ivermectin is an antibiotic. Is ivermectin an antibiotic?
I'm using the term antibiotic as a broad umbrella term to encompass all anti-infectives. I should have used the word anti-infective.
Okay, thank you.
Follow-up.
Follow-up, yes, thank you, Mr. Chairman. There are other drugs that are introduced onto the market that have a high efficacy, and you may need to take training to learn about them. Now, the standing order, you said, or an official with your standing order has to write out the procedure on a piece of paper. Is that posted in the pharmacy, or how do you know about a standing order?
typically the pharmacy, if they've elected to opt into a standing order, would have that piece of paper on file in some filing cabinet and if required by statute, a training plan in place. So an example that somebody brought up was the oral contraceptives. So I am not an expert in prescribing the correct dose of oral contraceptives to patients. There are probably 50 different variations of that medication. But if I took an accredited course on the selecting the correct dose for a patient based on a number of factors, weight, age, what they're using it for, whether it be, acne or other for contraception itself, then I might be qualified to help them choose the correct dose for their indication. But, without having clear guidance on what this medication is being used for, there's a variety of indications for it. It'd be difficult, I think, to have one standing order that would cover all of the uses of the medication.
Hello.
Thank you. So there have been 3.7 billion doses around the world that have been administered to people. And there's probably a very large file of how this particular drug interacts. And if a doctor or whoever writes a standing order, don't you think you'd be able to handle that? I mean, even if you have to have special training, what if it wasn't ivermectin? What if it was pectamycin or something, and it cured cancer, and all of a sudden we had a standing order for this particular drug, a hypothetical drug? Wouldn't you be willing to take the testing and the course necessary in order to fulfill the standing order for the betterment of the people in the population who might need it?
Some pharmacists may be willing to do that. A lot of this comes down to our training. We are not prescribers, we're not diagnosticians, so pharmacists are trained in better understanding of medications, interactions, dosing, things like that. So it's outside of our traditional scope to be using a standing order. So it does require that additional training. So I think some pharmacists in the state may be interested in that, but as I mentioned in my testimony, pharmacists are overworked, stressed. This may be something that is really low priority for them based on the additional workload that they already have. So asking a pharmacist to be prepared for patients to come to the counter and demand this medication, I think is challenging for my profession.
Thank you.
Representative Weber.
Thank you. I just wanted a clarification. If a standing order was issued under this, as it's currently written, would a pharmacist be required to dispense ivermectin, or would they be able to choose whether they want to undergo that or not?
In my experience, that's a choice that's made. As I alluded to the oral contraceptive standing order, not all pharmacists are trained and do not opt in to provide oral contraceptives to every patient that would ask for it. I think it really, again, I'm going to reiterate the workload that a lot of pharmacists would probably have trouble if they weren't well trained in this particular standing order. They'd have difficulty, dealing with members of the public who are expecting for it to be available to them.
Representative Kesselring.
Thank you, Mr. Chair, and thank you for taking my question. So how would this vary for the information that a pharmacist would have to give to somebody that's not even a prescription, but over the counter, if I were to say, come in and ask you for questions about NSAIDs or something along those lines? Let's say I have an allergic reaction to it or something like that. How would that differ from what ivermectin conversation would be?
So I'll try to give an example. So if you came up to the counter of the pharmacy and asked me questions, typically if I didn't know the answer, I could consult a reference to be able to provide you evidence-based information about that. My understanding of a standing order would require that, it's a deeper conversation that you have with the patient. What's been going on? What are your symptoms? How long has this been happening? What have you tried so far? Have you spoken to your physician about this? It's a lot more of an in-depth conversation, my guess, outside of just a quick consultation with a pharmacist about what's the best medication for lice treatment or something like that. Does that answer your question?
Follow up?
So I guess to expand on that is what I'm looking for is specific things that you might have to do differently. Like I mean, when it's over the counter, if this were passed to be over the counter, then you would have to have a parameter, right? Because I mean, obviously, if you're allergic to NSAID or if you have a question and you're asking about its prescription, or I mean, over the counter, you're going to have different parameters. I mean, I'm sure that there's policies in place for those companies that might not be able to give you that information. Is that correct too? I guess. You know what
I don't know that I'm following your question. I'm sorry.
I mean, let me rephrase.
Sure.
Is there any reason that a pharmacist would not be able to give you information on ivermectin if it was over the counter?
No, probably not. I mean, our standard would be we could provide information on, recommended dosing for a particular indication, side effects, interactions, things like that. But, again, selecting the appropriate dose based on the indication when we're not diagnosticians, we can't diagnose, is not within our scope typically. So that would be a different conversation. Yes.
Representative McLean.
Yeah, just quickly. So a standard order like this, who would write it? Does the chief medical officer of the state write it and it goes out to everybody in the state and it's one universal standing order for the whole state? Or would each pharmacy reach out to it? Logistically, how does that work?
I think I've seen both. So I've seen situations where there's a statewide standing order, for example, naloxone, where the chief medical officer for the state does sign that, and any pharmacy can take advantage of that. I would anticipate that this would be a standing order that we would need a physician or a provider with that licensure to opt in to be the signatory on every order that's dispensed for ivermectin.
And that would be for your chain. So CVS might have its doctor and...
Correct.
Thanks.
Anyone else? Seeing no one else. Thank you.
Thank you.
Also signed up to speak is Maura Weston from the New Hampshire Medical Society.
Good afternoon, Chairman McDonald, members of the committee. For the record, my name is Maura Weston, and I am here today on behalf of the New Hampshire Medical Society. I am here today in opposition to the amendment before you on behalf of our 2,000 plus physician and medical student members who live in and treat patients in New Hampshire. We are opposed. The primary mission of the Medical Society is to advocate for and promote public health issues that impact patients. The patient-provider relationship is of utmost importance to our members. We're opposed to this amendment because it singles out a specific medication in statute and sets a precedent legislating prescribing practices. With over 23,000 FDA-approved medications, we believe it does not make sense to legislate medicine. Few physicians would endorse delegating the prescribing of ivermectin to pharmacists. We rely on the importance of the patient-provider relationship and appropriate prescribing practices based on medical history and conditions. With that, we urge you to recommend this amendment inexpedient to legislate and maintain the integrity of the underlying bill. And I'm happy to answer questions if I can.
Thank you.
Thank you.
Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question.
Sure.
We heard testimony that ivermectin is a safe drug. And the debate is over how it should be dispensed. And there are, though, we heard cases from the pharmacists where we do have standing orders in place. So what is it about those things for which we have standard orders in place currently versus ivermectin that you would think makes them good candidates for standard orders versus the ivermectin, which is a safe drug, not be a good candidate for the standard order?
Sure. Thank you for the question. I will be perfectly upfront that I am not a physician, so I may not be best qualified. However, it's my understanding, generally speaking, that in cases where there are standing orders, those orders are there because of emergent circumstances. For example, naloxone, that's one with which I am familiar. And so I would suggest that there's a different standard in the case of those standing orders, and that in this case, we would prefer to rely on that conversation between the patient and the provider.
Follow-up.
And just forgive my ignorance. You mentioned that you're familiar with the naloxone case. I am not. So maybe it might educate me a little bit to say what was the condition that said this is something that should have a standing order?
Again, I think that might be a better question for DHHS or state officials. I'm not a doctor, and really my perspective on that is from the perspective of a layperson.
Representative Palmer?
So naloxone is for drug overdose. So if you wait to get a prescription, the person's going to be dead.
So it needs to be done.
Yeah.
Anyone else? Any other questions? Seeing no other questions, thank you.
Thank you for your time.
No one else has signed up to testify on this amendment to SB 119FN. Does anyone else wish to testify?
Just literally 2 statements, real quick.
Well, it's unusual for anyone to speak twice. Well, you can speak to it. We can speak after. That's fine. We usually don't let anybody speak more than once. I'm sorry. Anyone who has not yet testified, does anyone wish to testify? Seeing none, I am going to close this public hearing on this amendment. No other legislation is before us today, so that concludes our business. We will be reconvening next Wednesday morning at 9:30 a.m. And being hearing other Senate bills. With that, we are adjourned. Thank you.